Can you hear me?
It's live now.
Yeah.
But it's live now.
Yeah, okay.
Go ahead, Dr. Bang. You can open it.
Yeah, sure. Hello, everyone. I'm Dr. Vijay Bang. I'm the organizer and moderator of the program, and I have a very eminent faculty with me, Dr. Sameer Parekh, chairman of Cleveland Clinic Cardiovascular Department, and Dr. Amar Krishnaswamy. He's the head section of the interventional cardiology and mainly looking into structural heart program, and also the program director for the interventional cardiology fellowship. And then we have Dr. Sushil Kudali. He's my very good friend, and we have too many common friends. So, and Sushil is of course from Columbia University. He's, I think, director of the CAT labs. So let me give some opening comments on TAVI program. Soon after the partner trial was over, the result was the procedure reduced 1 year mortality by 20%. There is no other procedure in the arena of interventional cardiology which reduced the mortality by 20%. So by one study only, they directly got FDA, US FDA approval. And it's a degenerative disease which is seen in elderly population. And in Europe and in America, the elderly population is in large number. I'm told in America alone, there are 40 million people who are in the elderly age group. So an incidence is 7% around. An average age of having a TAVI is 84 years, and about 30% people are above 90 years having TAVI. Now, this is definitely a life-saving procedure, and it prolongs the life for sure, because if you have angina, life expectancy is 5 years. If you have syncope, life expectancy is 3 years. And if you have heart failure, life expectancy is 2 years. So having TAVI definitely prolongs life without the doubt. Now, with the advancement of the technology, various aspects of the whole spectrum is being covered now, including, I'm told lately, there are studies that even rheumatic heart disease will be covered by TAVI. So it's a kind of important boon. We started with all inoperable cases and frail subject. Those who have STS score of more than 4, and now it is expanding to intermediate and lower strata also of the risk. So it's all in all excellent, I would say. And let me request Dr. my co-moderator, Dr. Sameer Kapadia, to invite Dr. Sushil Kudali as a first speaker.
Thank you very much for organizing this, Vijay, and thanks Sushil and Amar for joining. We have an outstanding program and outstanding faculty to run this particular session. We are going to start with the TAVR, and then we'll talk about the mitra clip in 1 hour or so, 1 hour and a half. Dr. Kodali, as you probably all know, that has been instrumental in starting the TAVR all over the world, and he is one of the most expert and incredibly talented structural interventionalists. But in particular, he has a great insight into how TAVR has evolved, how TAVR complications have become less and less, and how to have proper imaging to make the TAVR a success. So, Sushil, again, thank you very much. It's early in the morning to join us and show us the first talk, which is the CT imaging for TAVR. And thanks for your insight.
Thank you, Dr. Bang, Sameer, and for inviting me. And I'm sorry we can't be there in person. hopefully in the future we'll be able to join in person. But this is a true pleasure, and there's a lot that we can discuss, and an hour is too short for any one topic. But I think the program sort of highlights some of the keys, and I think one of the challenges as technology gets distributed is how do you train people, and how do people have enough experience to do the procedures? Because there's a learning curve for anything that we do, and I think the goal of programs like this and others is that maybe we can shorten that learning curve, and maybe we can prevent mistakes from being repeated that we had done in our early experience. Samir and I had the good fortune of being involved in the partner trial from the early stages. The first transcatheter valve procedure I was involved with is in 2005 with the antegrade transvenous system, with the original Cribia Edwards, where he went through the vein, did a transeptal, looped in the LV, and came out. And that, we did a couple procedures and they neither went well. Then it went to the retrograde transfemoral system, and we just we looked at the echo, transthoracic echo. We had a 23 millimeter valve, and we just sort of put it in. We didn't understand. And I think we didn't really understand the anatomy until probably, 7, 8, 10 years into doing the procedure. And a lot of those early complications we had, if you looked on CT, we could prevent, or even looked on 3D echo, we could prevent. So I think the goal here is to learn, what we learn from these technologies, and to sort of prevent some of those same errors from occurring. And really, why you need to, and part of the role of CT and echo, and we're not going to talk too much about echo here, but it does play a role in sizing as well. But we've really moved to CT-based sizing in the majority of patients. As long as they can get a CAT scan, their appropriate sizing can be determined. And the reason to size is, one, mainly to anchor the valve to make sure it doesn't embolize. It has to be oversized enough in the calcified leaflets that it needs to anchor. And it's important that anchoring doesn't just occur by oversizing at the annulus, but it's based on the friction of the calcified leaflets. And this is especially relevant when you talk about bicuspid and rheumatic disease. Then the valve has to seal. It has to be opposed to the annulus enough that it seals. And then it has to be fully expanded so the leaflets can function. If you underdeploy a valve too much, yes, it will anchor, but if the valve is too crowded, it's not going to seal. So what have we really learned? Oops, excuse me. Oh, sorry about that. As I said, we started with, what's going on here? Sorry. We started with echo for sizing, and we used the 2D measurement. And Samir remembers all of this and how we sized and didn't really understand. One of the key things that we learned on echo, and this is part of before we use CT, is oftentimes on echo we'd look at this long axis view and we'd look at where we see both leaflets and size the annulus. That's because we didn't really think of it as a 3D structure. And if you're seeing both leaflets in a three cusp valve, you're cutting off access. If you really are looking at even the one plane in a perpendicular axis, you'd be cutting through a commissure as you are here. So when we learned this, then we started using, we had a 3D TE came into use. And so we'd use the 3D probe, do X-plane on this short axis, try and get an on-axis view, do X-plane here, and then cut across. And in this other view, you wouldn't see leaflet, you'd see a commissure, and then we'd measure here. But that would be a single dimensional measurement. And so we did this all the time. We'd sort of try and understand the root, try and get perpendicular, and try and make that measurement from edge to edge. At least get a single measurement that we thought was on axis. And that was the initial sizing. And then we oversized based on that. And we oversized anywhere from 10 to 20%. And so, but this paper from Nick Piazza, it was 2008, was really sort of instrumental, sort of to frame the discussion that the annulus is a complex three-dimensional structure. And it's not really a circular structure. And so these cusps have naders and peaks, and the attachment points of the commissures vary along, depending on where you are along the annulus. But there are three sort of points at the nadir of each cusp, and we're really talking about normal tricuspid valves, three cusp valves. and not bicuspid valves. And so that really, when you look at it this way, one single diameter can't characterize the annulus size because it's elliptical and it's non-circular, and it's really variable from patient to patient. We've had patients that have an ellipticity index of like 1.2, where the min and max is really variable, and others where it's more circular. So it's not a uniform. And so it's, 50% of patients is oval, and the mean difference between the coronal and sagittal patients in the study from the Vancouver group, it was around 3 millimeters. And the reason that's relevant is when you size a valve, you're going in 3 millimeter increments. So the mean difference between the min and max is 3. That's one valve size. So that's why it's really important that you're not sizing in a single plane. And that, the reason that we got away with it in the beginning, when you take that single measurement through the cusp, that's typically an average of the two. But, this is why you get into trouble if you size in a single plane. This is a single patient that was, published early in the experience. On 2D echo, it's 22. On CT, if you get on axis, it's 22 by 28. So if you put a 23 valve here, you're going to be undersized and you're going to have significant PVL. And that's trying to illustrate that. So we've learned from that initial experience in those first 5, 6, 7 years that we got to look at better sizing, look at 3D sizing. And we really have to use CT to help us do that. So the advantages of of a CT is you really go from a single plane 2D measurement to a 3D analysis. You are getting on axis, on perpendicular, and then you're getting this short axis just at the annulus or just below the annulus. And then you can make your measurements in 2D. But once you're perpendicular and you've created this 3D structure, then you're more accurate. And the advantage of CT is it's more reproducible, it's less operator dependent, and things like that. So the goals of the CT are assess the aortic annulus, but not just the annulus itself, assess the surrounding structures. You need to assess the aortic root, the STJ, the coronary heights, the aorta, assess vascular access, look at where the calcium is, especially in the peripheral vessels. Is there a lot of calcium or tortuosity? In the annulus, is it bicuspid? Is there a calcified raphe? But one of the challenges with getting CT as you go to these older patients is a lot of them have renal dysfunction. And so you need to minimize harm to the patient. And so some patients you can't do a CT scan because of renal insufficiency. I don't really worry about radiation dose in this elderly population. And I'm going to talk briefly about CT. And some of it is outdated, but I think it's relevant because these are the scanners that we're using. And I think as cardiologists ordering these scans, we have to really understand what we're asking for from the radiologist. Because if you don't ask for the right scan and you don't know that you're not getting the right information, that's worse than not having the information itself sometimes. And so there's two components to the scan: the cardiac, which is sort of an axial and in most cases a sequential scan, and the vascular, which is sort of a helical and sort of go down and look at the vascular access. So when you talk about the cardiac scan, you really want to go from the STJ in the cranial dimension to ideally the most caudal portion of the heart, but you need to cover the annulus. The aortic arch can be within the scan or in the vascular scan. You need small slices. You can't do it in 3 millimeter slices. We use 0.6 millimeter slices, anywhere from 0.5 ideally, up to 1, although not ideal, is acceptable, and you need to give IV contrast. And so you need to think of things when you're talking about the cardiac scan, the scan length. So how much is it from the STJ to the tip of the heart? Is 8 millimeters enough? 8 centimeters enough? No. 16 is probably enough if positioned well. And so you need to think of that. How much is that length? And how much contrast do you want to give? And the scan has to be gated. And you need to find the best images in the cardiac cycle with the least motion. And as opposed to a coronary CTA, and we'll talk about the reasons why, you need both systole and diastole. So we do retrospective gating, as I said. We don't worry about minimizing contrast and doing prospective gating. And you need to try and have patients hold their breath to minimize motion artifact. Again, difficult sometimes in the elderly population, but if you want to get a good quality scan, that's what you need to do. And so, we use a 320 slice, which gives us the full length for the cardiac scan. And so the patient doesn't have to move through it. And for the helical scan, where they're getting from the neck down for the vascular. It's just continually rotating the tube around, and the patient moves through the scanner. But the key question is the axial scan for the cardiac. And you know, I'm just going to talk to this. It really, you need about 16 centimeters if you want to get the entire thing. And depending on the number of detectors you have, whether it's a 64 slice, 128, or 320, that determines how many scans you need to make to get a heart. So because the usual width of a detector is about 0.5 millimeter. And so each acquisition is a volume. And so let's say you have a 64 slice and the detectors are placed at 0.625 millimeters. That means each scan is 4 centimeters. And what that means is with each scan, you get about 4 centimeters of rotation, which won't capture the heart. So you need about 4 acquisitions to capture the entire cardiac portion. So it's going to scan once, step the patient in, scan again. If you have a 128 slice, you're going to need 2 acquisitions because each scan is about 8 centimeters. If you have a 320 slice, you can get the entire heart in 1 scan. The reason that's relevant is in these patients in AFib that can't hold their breath, each acquisition you have to do, you have to combine them together. And that's where you get step artifact. And that's what's relevant. And it's also relevant because you can minimize contrast dose, because each acquisition takes about a second. And if you're giving contrast at a rate of anywhere from 3 to 5 milliliters per second, and if you can get a 320 slice and you get the entire volume, you need less injection of contrast. Whereas a 64 slice, where you need 4 to 5 volumes and you're continually stepping the patient through, you need to give more contrast. So, you know, we use a dedicated scanner. That's a 320 slice. We have cardiology read the scans. I review all the scans on my patients. We encourage all the cardiologists to review the scans. And the other thing to remember is when you scan these elderly patients for aortic stenosis, you often find other things that you need to follow up on. Once you get the scan, you need to analyze it. Vascular access is pretty straightforward. You know, we do these 3D reconstructions ourselves using a dedicated software package. There's multiple packages out there. In terms of the annular plane, what you need to do is find 2 perpendicular planes, the coronal and the sagittal. So you rotate these so that they're perpendicular. And then if these 2 planes that are 90 degrees off are perpendicular, then you're going to be perpendicular to the short axis of the annulus. Here's as you go to the valve, then you go down to just below at the annulus. And so what you see here is by having these 2 oblique planes, your short axis is then perpendicular to the annulus. And you can rotate around to make sure you're perfectly on axis. You come down and then you make your measurements. You can make a mean diameter. We generally use area for balloon expandable and perimeter for self-expanding. But at the same time, I look at the distance to the coronary arteries, the width of the root, the width of the SDJ, width of the aorta, measure the length of the ascending aorta, all the other measurements you have to do to look at it. In terms of the coronary heights, you can either measure them directly or obliquely. And those are relevant because these heights are related to coronary obstruction. There's a lot of packages out there. We use 3Mencio. There's numerous others. But it's important, as I said, to get the entire cardiac cycle. You know, in general, for coronary CTAs, and most of your radiologists will give you a diastolic phase. There's a lot of variability. There can be a 10 to 15% variability between systole and diastole, and I think that's important. And so what you don't want to do is just get diastole, and if it's in the gray zone, understand that it may be relevant. The reason we focus a lot on CT, early studies back in 2012 showed sizing with CT can reduce paravalvular leak. The one thing I want to emphasize at the end here is that a poorly analyzed CT is dangerous. So here you're not oblique. You can say this looks like relatively good for the annulus, but you're cutting through the leaflet here and you're not oblique. And I think in this green plane, as you can see, you're not at the hinge point. This line is going through the thing. So you need to do careful access. And then understand when there's artifacts. When there's artifacts, don't rely on the CT. This is what I mean by when you use a 64 slice, you get these step artifacts that you have to stitch acquisitions together. This slice goes through the annulus. And in patients in AFib who can't breath hold, it's very difficult. And so sometimes you also get motion artifact. And so understanding when there's artifact is important, because that's what's a bad quality scan can be dangerous. So what is the role of echo? Echo has advantage over CT in that right now it has better temporal resolution, and you can see the moving hinge points. It obviously has the physiologic information. It eliminates motion-based artifact. You can see the adjacent structures, and you eliminate some of the hand tracing errors. But there's some pitfalls. Lateral resolution in the coronal plane, which is often the long plane, is not as good. There's a lot of acoustic artifacts with heavy calcium, and it's really operator dependent, and you got to put patients through a CT. Patients through a TE with the invasive nature. CT is just better tissue lumen contrast. There's less inter-observer variability, but there are motion artifacts. You can get some blooming artifacts. You have to give contrast, and it's really dependent. And so, we generally now, I would say 95% are CT based. In patients with really poor renal function, we'll do the TAVR TE guided with no contrast, but that's the uncommon thing. Most of it's a weight based on the CT sizing. But it's important to understand that echo can be used. The 3D echo machines can do the same multiplanar analysis, right? This is exactly what we did on the CT package. You get two oblique planes, and then you get this annulus at size. So this can be done, and we've shown in our group that it's comparable to the CT measurements. But it's a skill set that needs to be acquired. But the 3D probes are really great now, and you can do all of this. And whether it's by CT or by echo, you can get these double oblique planes and very comparable measurements in this particular patient. You can do the measurements to the left main as you do on CT. You can make measurements of the root, which are the same. So, they're different, but they both are useful as a tool. But the measurements are based on the location of the annulus, and echo and CT may measure slightly different things, but both are valid. But a good quality echo or CT is better than a bad quality echo or CT. Don't be married to one modality. Be confident in the imaging, that you're imaging the right structure and you're seeing everything else. And there's a lot of technical differences, and you need to understand what you're looking at, understand the limitations of both echo and CT, and look at what the virtual annular plane and understand what you're doing. And there's just, in echo, this is same patient, you get shadowing at one level, you go a little bit deeper, you get better imaging. So CT is an essential tool for pre-procedural TAVR planning to assess the annulus size, surrounding structures, vascular access. You need to optimize imaging while minimizing harm of the patient. So understand the scanner strengths and weaknesses and how to maximize its abilities. We do CT scans with 40 cc's of contrast in these elderly patients, which we think reduces renal risk. Use the analysis tools yourself, whoever's doing the procedure, to analyze the CT, understand the risk for complications, and optimize pre-procedural planning, and understand the limitations of both. Thank you.
Thank you very much, Dr. Kodali. It was excellent presentation. And we all know that now echo versus CT has become an interesting aspect in evaluation of the aortic valve severity and the probability of the further treatment. Discussion we will have at the end of all the talks, a detailed discussion. In the meantime, I request Dr. Kodali to invite Dr. Samir Kapadia as the next speaker.
So, Samir and I have known each other for more than a decade now. As you said, Dr. Bong, he's now the head of the Cleveland Clinic, chair of cardiology, and has so many other roles, and has been a leader in the field, both in coronary intervention, cardiology, and structural heart disease. I've had the good fortune to work with him very closely on the partner trial and other trials in both now mitral and tricuspid disease, and to really help drive the field of structural heart disease forward. He's been an instrumental leader, a thoughtful leader, and really helping to drive the field and provide better care. So it's my pleasure to introduce a friend and colleague, Samir, to give the next talk.
Thanks, Sushil, again for a kind introduction. And, this is our pleasure and, honor to be part of this thing. So what I'm going to talk about is a very simple thing, that what is new in TAVR. Now, just so that we know that the TAVR is a very mature technology. When we started to talk about TAVR, compared to sternotomy, to go minimally invasive, it has become a reality. Lots of people, lots of patients are now being treated with TAVR. So this is now uh, no longer a technology that is being tested or anything close to that. In United States, the TAVR has expanded tremendously, and you can see that how much distance you have to travel to get to a TAVR center is decreasing. So, in United States, 10, 80, 10, 15 miles is 10 minutes. So it is a very, very close distance to which you can go and see TAVR. And of course, the TAVR has several different areas, as Sushil pointed out, that the most important thing is that in surgery, it is exposing the patient, understanding the exposure, understanding the valve. So seeing the valve, cutting it out, putting a new valve in place, suturing it up, and then closing, making sure that there is no leak around the valve. So these steps have to be replicated in transcatheter valves. So you have to see the valve. That is what the CT and echo was all about. And then you have to accurately place the valve and make sure that the result is excellent, meaning that there is no leak around the valve and the hemodynamics is adequate. So this is the TAVR team. And you can see Amar there. I brought a little bit older picture so that we look younger. And also I have Dr. Tuju, Dr. Swenson. All of us are here together. And we all meet, and this is before COVID, so no masks, but we typically meet now virtually. And what is the most important thing is that in the past, we used to discuss the surgical risk. The surgical risk is now no longer a very important part of the discussion. The most important part of the discussion is the TAVR risk or the anatomy of the TAVR. So this is where, again, the field is changing, that we are more interested, as Sushil pointed out, in the anatomy rather than the surgical risk. Because if the anatomy is good, TAVR is the choice. If anatomy is not good, then we worry about the surgical risk and try to understand that what the surgery has to offer. This is our typical slide that we make. And you can see that this slide is an important slide to say that what are the past medical history. Like this guy, he's 77 and just has one prior surgery. So in 2005 and 6, we would say this is a super low risk patient, that this is not a even intermediate risk patient. Now we say that, okay, this is not the focus. The focus is that what size valve we are going to be able to place and what is the anatomy, what is the sinus size, how the second valve will be able to be placed, what is the coronary things, and how is the access. So I want to show you one case so that we can discuss the details. Here you can see that this is our setup. So although the room is tremendously large, there are very few people in the room. And what the room consists of is that there is actually a pump available in the room, which is, again, as you see, covered. And we don't use it, but it's very important to recognize that even 2 or 3 patients a year out of 500 to 700 patients that we treat, if they require to go on pump, the pump is readily available. So within 5 minutes, we are able to put the people on pump. Anesthesia nurse practitioner is available there. Cardiologist and cardiac surgeon both are scrubbed at the procedure. Very important that the cardiac surgery colleagues are involved not only in the decision making, but also during the procedure, that they are available and that they are engaged in the patient care. One echo technician is available, so the transthoracic echo can be performed right away, and one nurse. So again, the amount of people, the number of resources, very limited, but at the same time, super organized. No general anesthesia, no Swan-Ganz catheter, no arterial line, no Foley catheter. So none of this is necessary. So what is necessary is also there, and what is not necessary is also there. Now, how we do this is a little bit different. So this is a groin access. So we first get the groin access, and we try to go just below the inferior epigastric artery as high as possible. So this is the first sheath. Once you put the sheath, we just put one perclose, single perclose, not 2 percloses that most people put, just single perclose. And then we put an 8 French sheath there. So just put a single perclose and an 8 French sheath. Then this next step is to get another access. So in the same groin, so not in the contralateral groin, no crossover sheaths, none of that. So just put a second needle just that much below. So this is typically 1 inch below or 2 centimeters below. So if you can imagine, this is a 20 millimeter or 24 millimeter stent. So that much below that you can put the sheath, just palpation. And sometimes if the common femoral is not long enough, go in the SFA, it doesn't matter. And just put the sheath there. And there we put a 5 French sheath. So this is an 8 French sheath with 1 perclose, then 5 French sheath underneath. And this is the venous sheath for the pacemaker. We always use Sentinel. So this is the device that protects the cerebral embolization. So this is in the right radial artery. So no sheath on the left side. Now what we do is we will put a Sentinel there, and then there is a straight flush catheter. And now we connect it to the anesthesia people or the outside, so they can give medications, they can monitor pressure, things like that. This is our setup. So the setup is very nice to say that we are fortunate enough to have a biplane room. So this is a biplane room. And here you can see that we have a hemodynamic monitor, a transthoracic echo monitor. These are the reference images. And we have that slide that I showed you, so that in case we want to refer during the case that what is the creatinine or what grafts the patient had, we can readily look at that. And we have an injector available to inject dye at any point in time inside of the to measure the aortic regurgitation. So now this is the Sentinel device. So many of you probably know this, but this is a device that actually Sushil and myself worked together, and we did a clinical trial. We are the co-PIs of the clinical trial, and this is the device that goes in the ascending, from the wrist. It's a 6 French device. You first put a proximal filter, and the proximal filter is placed. Again, this is live in the sense that I didn't trim the video or anything, so it just takes that long. So it goes on an 014 wire. You deploy the proximal filter in the innominate artery. So that will cover the right carotid artery and the right vertebral artery. And the filter is such that this filter has a filter like this. This is the ring, and the filter is like this. So the blood flowing through will go through the filter. And now you pull back the wire and then flex the front end. Make sure that you don't hit the inner arch of the aorta. This particular patient has a little calcification, so that's why I kept it there. But normally we know how far the aorta is. And then we flex the distal end. We put a small wire as you see that the wire went into the carotid. Then we'll pull this back. And once this is pulled back, we push the distal filter out from the back. So that distal filter will come out right there in a second, right, just like that. And so now the 2 filters are placed. This is in the left carotid artery. So very, very simple procedure. And now we put the straight flush catheter. So a lot of people put a pigtail catheter. We use a straight flush catheter. The advantage is that we don't have to remove the catheter when we are deploying the valve. So again, a very important thing. And the second thing is that we use it in the non-coronary sinus. So there are 2 ways to deploy the valve. Some people put it in the right coronary sinus. Most of them put it in the non-coronary sinus. So non-coronary sinus, in our opinion, is better. And then we have 2 different views, but normally we focus our attention on this RAO caudal view. So the RAO caudal view, and I'll show you how we decide how much RAO and how much caudal, but the idea is that the right and the left cusps are superimposed on the front, and the non-coronary cusp is isolated in the back. So this is an important concept to keep in mind, that where is the non-coronary cusp. The first step is to check the hemodynamics, and we are interested in knowing that what is the end diastolic pressure of the left ventricle up front, what is the dicrotic notch like, how far is the dicrotic notch is in this downslope, and what is the aortic diastolic pressure, and in this case 60. So these are the important information: the LV end diastolic pressure, aortic diastolic pressure, and where the dicrotic notch is, obviously the gradient, but that is in the pre-assessment of the patient. Now when we are going to deploy the valve, this is the trick. So this is a Edwards Sapien valve, whether it's Sapien valve or a core valve, the concept is similar, that we want to put the valve right at the lower border of this sinus. So we don't want to go anything below the native annulus. So how do we do that? So first, we put this valve in such a way that once the valve is placed in the RAO view, we adjust the camera so that the valve has no parallax. So once the valve has no parallax, then we adjust that white line, that the last link of the stent, such, so this is the last link of the stent that is at the bottom of the annulus. So the valve will shrink about that much when we are deploying the valve. So this is an important concept to keep in mind, that how much the valve shrinks. And roughly this is true for all the valves, and 29 valve shrinks a little bit less. So you can even put it a little bit higher. And then if you look at the RAO view, this is the coplanar view that is normally, all the three cusps are seen. In this view, it looks high because the non-coronary cusp is the lowest cusp and we are putting it at 0. So that's why this view, it will look a little bit higher. But we don't use this view to deploy the valve. We are using this view to deploy the valve. Once we have deployed the valve, we check that we place the valve exactly. We have not removed this straight flush catheter. Straight flush catheter was there to guide us that where exactly to put the valve. And we can adjust it with the slow inflation. We can adjust the valve. And again, you can see it's exactly at 0 level. Then if you go further, you can see here that we do an aortogram. This is very, very important. So the aortic assessment has to be done with 3 different things. So one is an aortogram, and we do it, of course, in a biplane with a good injection, and make sure that there is no aortic regurgitation, not mild aortic regurgitation. We also do the AR assessment with echo right away. And this echo is very important to make sure that we don't have any aortic regurgitation, but also not have any complications like tamponade. And it is important that what we try to do is to decrease the aliasing velocity. So instead of keeping the aliasing velocity to 69, we make it 39 so that we can see better. And if there is no AR, even with a low aliasing velocity, we feel better that this is a good result of our intervention. And then we look at the hemodynamics. So the LV and diastolic pressure should not increase. Sometimes it increases because of the pacing in the low, if the ventricle is not normal. But again, we look at this slope. So if this is in diastole, if there is a lot of AR, the slope will be faster. So this is not much AR at all, or no AR. And then we look at the dicrotic notch. And if the dicrotic notch is above the 50% of the downslope, we think that there is not much AR. If it is not, that does not mean they have AR. It could be related to compliance, but the negative predictive value is fairly high. So these are the different things that we look at. The mild AR, if you have, we call it a TIAR index. So this is related to, very similar to the AR index, but it is independent of the heart rate and the dicrotic notch, as I mentioned to you. And then Dr. Krishnaswamy also wrote this paper. We have designed this strategy to say that we pull the pacemaker out of the right ventricle and put it in the put it in the RA. And from the right atrium, we pace. And we pace at 120 beats per minute. So if you can go up to 120 beats per minute, one-to-one conduction, that means that your AV node is good. If you cannot, let's say that if you Venkiback at 100 or 110, that does not mean that you have a bad conduction. That just means that your AH interval is blocking such that you cannot assess the HV interval. So in that situation, we don't know that how good or bad is the conduction, but at least if you can conduct one-to-one at 120 beats, that means you have an excellent conduction and you can even discharge the patient the same day. And that's what we typically do for these patients. And then we do a completion angiogram. So now, very simple. So you go in, we remove the sheath from the top and put one perclose. If there is an issue, we put one more angioseal. And so in about 60% of cases, we need an angioseal. 30% of cases, we don't need an angioseal. And then we take a picture, and I brought a picture such that the result is not excellent, in the sense that there is a slight problem there. No big deal. In this situation, we just put a balloon right there from the lower sheath. So you just go in, inflate the balloon from the lower sheath, then pull the balloon, not inflate it all the way, 2 atmospheres. Then you pull the balloon back just like that, and then inflate it in the area of interest to a higher pressure. So normally from a 5 French sheath, you can easily put 6 millimeter balloon. If you need higher, then you can put a 6 French sheath in that groin if necessary. And then retake the picture. And if it looks good, like this, in this case, it looks excellent. So at that point, you will take the sheath out, hold pressure, and then give protamine. So the lower sheath does not need anything, just a manual pressure. So this is the way that we have been doing towers. This is the team, that I took a picture with. And all of these things that I mentioned have literature from us, our own experience that we have published. So we are doing general anesthesia versus MAC. So everybody in MAC these days. So you see that we were doing general anesthesia in the past and now no longer general anesthesia. Outcomes are excellent. All-cause death, overall death, 3 years outcomes, very, very good. Unilateral versus bilateral access. Unilateral access is extremely safe. And if you look at the unilateral access versus bilateral access, and this was, just remember that these studies are a few years old. So because we started doing all these things that I just mentioned to you for at least 4 years or so. So this is a study that we did with the unilateral access, which we reported a while back. And again, no difference in any major issues. Single versus double perclose, same way. Again, large number of patients, but no difference in the outcomes. And this is the high deployment that I just mentioned to you. This paper was published recently, but again, we have been working on this for a long time, again, for 5 years. So this data are from 2017 or so. So if you look at this, instead of putting the valve with a pigtail, we put the valve with a straight flush catheter and higher. And you can see here that our nuances left bundle branch block went from 12% to 5%, 1 year aortic regurgitation, no difference, and pacemaker rate from 13% to 5%. We are implanting depth is 1.5 plus minus 1.6 millimeters. So meaning it's at 0 when we implant the valve. Permanent pacemaker, this is the paper I was citing you from Amar. And you can see this, and we did it with the help, we combined this with Tony Colombo, and very good. And here you can see that the overall outcome of the patients in Cleveland Clinic, 2018, 19, and 20, outstanding outcomes. 400, 500 patients, 700 patients, 700 patients, mortality 0.20, 0.4, stroke 0.2, 0.31, AR 0.8, 0.3, 0.3, and new pacemaker 5, 1.2, 1.4. So I just want to end there to say that the TAVR has provided a very important treatment options for the patients. Anatomy is very important. Long-term durability still needs to be assessed. And the heart team evaluation is more important than ever before because you need to know the anatomy of the valve. And thank you for your attention. And I think we'll move to the next presentation by Sushil to talk about some complications of the valve.
Thanks, Amir. So should I just go ahead and do you want me to go ahead and go through this?
It is up to Dr. Bang. Do we have a time, or you want to go and discuss a little bit rather than to talk about?
We have 15 minutes, so you can complete the talk.
We can complete the talk? Okay, sure. Go ahead, Sushil.
I'll go quickly because we're running behind.
Sure.
And then we can have a discussion. So
maybe I won't go through all of them. And so I know Samir set this up to make it look like Cleveland Clinic has 0 complications. Then he has me do the complications talk to say that we have all the complications. But but I think, I'm going to go through a few of these just to show you what we do. Vascular, again, the reality is it's common sense stuff, as Samir said. If you put a sheath that's bigger than the artery, you risk a complication. You can get away with it the majority of time, but you can't always. And things have changed, and everything is a risk benefit conversation. We did a case last week in a 92-year-old. The subclavian wasn't good, the innominate wasn't good, and nothing was good, but I didn't want to do a thoracic approach. So we did shockwave balloon of the aorta because there's a tight aortic ring, and the vessels were 4 or 5 millimeters in the iliacs. And we ballooned those, but we had a discussion that the risk of a vascular complication in that patient is not the 1-2%. We said her risk of a vascular complication was 10%, but we accepted it. So you have to just understand what you're willing to accept. And this initial publication shows that if the sheath to femoral artery ratio, meaning the sheath is bigger than the femoral artery by more than 1.05, then the risk of a complication increases, as well as if there's calcium. So we still do things differently. In contrast to Samir, we put the sheaths on both sides. We do still do a double par close. I'm showing an old technique. We cross over with the wire from the small access side to the right access side. And I don't think it's necessary in every case with the 14 French. One of the reasons I do it is we're sort of a training institution, and I think understanding how to cross over as a technique is useful. So for the fellows, I think it's a useful skill to have, because when there's a disaster, whether it's this or with an impella that you took out, the ability to quickly gain access, cross over, and inflate a balloon is an important skill. And that's part of the reason why I think it's still relevant. In the past, this is a large sheet. This is a 22 French sheet from the initial experience. We used to take a balloon over on every side, and then we'd sort of pull the per closes. The balloon is there. If there's a disaster, the balloon provides you a safety net. So for sites that are not experienced with large access, that don't do a lot of procedures, I think having a crossover wire and a balloon is an important safety net. So if you take the sheath out and you have a lot of bleeding, you just simply inflate the balloon, gain control to figure out what you're going to do, whether it's manual compression, surgical cut down, covered stent, whatever the issue is, you can be ready. So for sites that don't do a lot of large access, I think this is an important safety net. So these are older slides, but this can happen with the 14 French. If you put a 14 French in 3 or 4 millimeter arteries, you can have this. This was the 22 French, but again, had a disaster, an iliac injury. So this was the initial experience. We put a balloon up, then we just put a covered stent, and then we still closed the sutures with the per close, and we're able to manage it with an endovascular approach because we had the crossover balloon. And the patient did fine and ended up getting discharged. This was one where after the sheath removal, extensive iliac dissection and perforation. This one, we put the stent from the other side over the crossover. So this was the access side. We had already had a wire down here. So we just simply went over that wire and delivered a stent to treat that patient. And so just put a covered stent from the right side into the left side after the sheath had been removed. And again, able to manage it with an endovascular approach. So the crossover wire provides a nice safety net in these scenarios. The reality is you have to understand that it's not vessel size for the most part, it's calcium. And that's when I always got into trouble. This type, on this CT, you see this railroad track of calcium. These are the ones that are always a disaster. That's where they perforate, that's where the sheath gets stuck, that's where the sheath just doesn't go. And understand the limit. Sometimes you just not enough room. And you have to be willing to accept higher complications if you're taking borderline access. We know that with smaller sheaths, and this is the SAPIEN experience, the vascular complication rates in the trials went down a lot. But understand complications can occur anywhere along the vascular tree. This was years ago with our first experience with the E-sheath, and this is with the SAPIEN XT. And this was a tortuous abdominal aorta, and the sheath ended up perforating at the abdominal aorta. All these in and out motions, that sheath ended up perforating there, and the patient became very hypotensive. Ended up we had to put a coated balloon. We went up from the other side, and we deployed an endograft to seal the perforation, and the patient ended up going home with no problems. But understanding your trouble points, understanding where the risk is key if you're going to be able to manage it. You have to have all the equipment and the expertise. we didn't have a coda balloon in the room, the patient would have exsanguinated before we could have done anything. So having a balloon available, inflating the coda to occlude flow, if you can occlude the site of bleeding, you can have time to think and figure out how you're going to manage that complication. If you're not ready to control the bleeding, that's when things get out of control and you get in trouble. So you need to understand where does the injury occur and how am I going to control the bleeding? And that's the key points. So we talk about this tortuous vasculature. This is a patient with abdominal aortic tortuosity. The sheets kinked, all of the sheets kinked. So if you have elderly patients, small elderly women, kyphoscoliosis, not uncommon to have this. And what I do in these scenarios to minimize the risk, you have a pigtail from the other side. I just put a Meyer wire or stiff wire in the pigtail and keep it in to help straighten out the aorta while you're advancing the sheath. In this scenario, you see that it helps straighten out the sheath, the aorta quite a bit, and reduces that risk potentially. Calcium and tortuosity. If you're doing a core valve and you have a lot of calcified vessels, remember there's the nose cone can separate from the capsule. And if you keep pushing here, you're going to potentially injure the artery or rupture the artery. In these scenarios, go over a Lunderquist, overdrive the capsule to make it stiff, and watch on fluoro that it does not bend like that as much as you can. In the worst case scenario, put the core valve through a sheath. Put an 18 French sheath and do the core valve through the sheath. To Samir's point, always do a completion angio. If you don't do a completion angio, you don't identify complications early, and you can end up with a cold foot, 30 minutes later, which becomes a much harder thing to deal with. You need to understand what's going on. So this is an example. Sometimes you get the back wall with the perclose, or you create a dissection flap and you have flow. There's no bleeding outside in this case. You think everything's fine, and then the foot's cold a little bit later. A simple balloon inflation here tacks up that flap, and you get rid of that. I'm going to skip through this one. This is not as relevant, but left main coronary occlusion with TAVI is an important consideration. And the things that are predictors of a coronary occlusion are low left main origin, long left coronary cusp leaflet, and as well as a short, a small root. Oh, my videos are not playing. Unfortunately, so this is a patient where we occluded the left main, and the left main occludes by the native leaflet going across the left main, not by the frame of the valve. Especially when Samir is talking about these high deployments, understand the frame of the sapien or a core valve is going to be across the coronary, and when you do these high deployments, but that doesn't impact flow because flow goes through the stent. It's when you push the native leaflet across the left main that you occlude flow. And so you need to identify patients who are at high risk, and you need to be able to manage it. And in this case, we had a wire and a stent, and we stented it. And the idea is to bring the stent from the left main to the sapien valve here in this case. The idea is the native leaflet, which was pushed up over here, is now trapped below the stent, and the stent keeps the native leaflet from occluding the left main and helps preserve flow. Apologize here, these videos do not play. So the way we do it when someone's at risk for a left main occlusion, I do it BAV, inject, you look at flow. So I don't like to get a third access. One of the key things to keep in mind is crossing with a stent after you've occluded it with the native leaflet can be difficult because you have no guide support. So if on the BAV and based on CT planning, you think it's high risk for left main occlusion, you need to be prepared. So here we have a wire down the coronary, and I also have a stent, because then if you occlude, you just pull the stent back and deploy. To do that, I use a JL4 guide, which I pulled back here, and I use a guide with side holes. So that way I can do my aortograms through the guide with side holes. So the guide is pulled back into the root, has side holes. So as I'm going up, I'm injecting. So instead of a pigtail, I have a JL4 guide with side holes. So I'm sorry, all this, the videos are not playing, but this is again, we included this one. So you see here, as the sapien goes up, this is an older video. This is a sapien valve, not the S3. We occluded the coronary here. And then immediately post, the wall motion went down. On echo, this is with TE. You can see turbulence at the origin of the left main. And again, on angio, you see some obstruction of flow. So the patient became really hypotensive, required CPR briefly. So we pulled the stent back. And again, you're not stenting the left main, you're stenting the native leaflet. So you need to bring your stent back beyond the left main. This is the post-ill balloon, but the stent needs to come to here, which is where it comes. The stent has to touch the sapien valve because you need to stent the leaflet away. And then the LV function returned to normal quickly in this patient, and there was no more turbulence at the left main ostium on TE. Annular rupture, these are rare now, but when they occur, they're catastrophic. And so annular rupture occurs because either root rupture or annular rupture because there's not room for the native leaflets to sit or the valve is oversized. So when you have these calcified nodules, what this does is oftentimes the injury is not on this side. The injury occurs because this calcified nodule prevents the valve from expanding in this direction and it overexpands in that direction. And so what we have to do to try and minimize that is not, if you feel a lot of resistance and the root is full, don't continue to expand the valve. And this is, again, we have example here, calcified nodule below. The sizing was very reasonable. The sinuses were big, and I don't see the annulus size here, but it was a pretty reasonable size. We did it was a 29 valve. We did a BAV with a 25 balloon. Initial plan had been to do a 29 valve. And this was done awake. This is a Sapien 3. We deployed a 29. I think the sizing was like 570, 580. And you see here, we should have probably stopped there. But there's a waste here. Once there's a waste, the valve is not going to embolize. You can always go back and post-dilate if there's leak, but if you can never take back a rupture. So once there's a waste, if there's resistance on the inflator, I often stop at this point. It's very different. So immediately, patient hypotensive, echo shows a large effusion. And what you see here, you'll see contrast going into the pericardial space here. You see this? So the injury is right here going into the pericardial space. So you got to be ready to deal with it. And Samir mentioned that in their room, they have a pump. We have a pump just outside our room to be able to quickly get on if needed. You probably need to intubate the patient if needed to support, quickly drain the effusion. But if you don't have a plan to treat the rupture, you're just going to exsanguinate the patient. So you can drain and give back the blood as much as you can. You want to prevent hypertension. So we sometimes pace if the patient still has a blood pressure. And you got to think about, am I going to take the patient to surgery right away, right there, because you're in a hybrid OR? Or in this case, what we decided to do was put a second valve, just a little bit lower, believing that the leak was somewhere here. If we put a second valve, then the first valve becomes a covered stent. And we don't fully expand the second valve. We did it just till it touched the first valve. And the idea was that we could create a covered stent, potentially reverse anticoagulation, and maybe seal. And so that patient, I don't have the echo, but that actually, it worked in this patient, and it's sealed. And the patient was discharged 2 days later and not requiring surgery. So we've had a couple cases where we put a second valve to seal a perforation. Now, this was a while ago, and honestly, these root ruptures should not happen. I think if you're careful with the deployment and if you plan and identified high-risk patients, I think it should not happen. But we use TE in high-risk anatomies. You see how this is why perforations occur. Look, if you look right there, if you keep inflating a TAVR device that's oversized, I'll let this play again. Just watch where the red arrow is. It's at the root where most of the injuries occur, not at the annulus. And you see how that calcium is poking in. And if you continue to inflate, you may rupture through. The other thing that I think reduces the risk of rupture is a slow, controlled inflation. And the analogy I use is if you take a balloon and you have a pin, you can push the pin in slowly. And for a while, the balloon will not rupture. But if you take the pin and you go like this and do it quickly, the balloon will rupture. So if you push that calcium slowly, let it expand into the tissue, you're less likely to rupture. And I think a slow inflation is key for these type of things. And that's what we do in this scenario, right? As long as you don't go quickly, especially at the end, you do slow it. If you feel resistance and you're watching, you see how slowly this valve is going up. It will accommodate. But if you go quickly, you're more likely to rupture in that patient. So I think a slow inflation is key. So we use TE in high-risk cases. It helps you identify complications quickly. It helps you manage your deployment strategy. But we do probably about, right now we're doing about 95% awake, but we do about 5% asleep, complex bicuspids, high-risk root anatomy, or patients that can't tolerate awake. So, because understanding that, general anesthesia and TE has its own set of complications, so we try to minimize it. But we sort of feel that about 5% of patients, there is a role for TE. But in the end, respect the anatomy. These type of patients, if you look at CT, you are at increased risk. You can get PVL, you can get other factors. So don't try and push it in these type of anatomies. You understand in an ideal anatomy, the risk is low. In anatomies like this, the risk is higher. And so when you have severe LVOT calcium, you're in anatomies like this, and you can see even on fluoro, the valve is not expanding. It was an awake case. There was a fair amount of AR. We tried to balloon it. It still didn't go away, and we still had a fair amount. And we ended up, we did this awake, but we knew where the leak was going to be. We crossed with a wire. We put a plug, and we reduced the leak. It's not perfect, but the leak is pretty mild at this point. But we decided that was the only option. Continued expansion is only going to risk rupture, and it wasn't going to do. And the final echo looked really nice in this particular patient. So in retrospect, could I have predicted all these complications? Absolutely. So it's understanding what the risk is and being prepared to manage them. So I'll stop there with that, and save time for some discussion.
Thank you, Dr. Kodali, for accepting this second talk in a very short duration. I mean, yesterday I spoke to you and you accepted to give this talk. And thank you very much for that. An excellent talk. I must say that you've shown excellent range of complications that we come across while doing a procedure of TAVI, particularly calcium. Calcium is the one which is everywhere. It's a thing that is a big hurdle for all interventional cardiologists in the world.
Yeah,
so
whether it's
calcium is the one.
The valve, it's a problem. Yeah.
Yes. So now we can start we'll invite Amar. Dr. Kodali, can I request you to invite Amar?
So yeah, thanks, Amar.
His talk is on the mitral clip.
Yeah, I can introduce
1
minute to Amar. Of course, Sushil can too. But Amar is our head of our cath lab at Cleveland Clinic, and he also is the director of our interventional cardiology. So he is, of course, my colleague and friend and amazing operator. But Sushil, you go ahead. He's going to talk about, as you see now, because Sushil has another meeting coming up. So I don't want to delay him.
That's why I thought that then I'll invite you and let.
No, and I apologize. I can't stay for this entire session. I had arranged another meeting in about 15 minutes.
Okay.
I will have to head off, but it was a pleasure, and working with you and Samir and Amar, just truly remarkable. As Samir said, I've gotten to know Amar over the last several years, and his trajectory and his growth, and he's now the head of the cath lab, head of interventional cardiology, and really one of the foremost experts in structural heart disease, and across the board from TAVR to MitraClip and others as well. So I think it's very exciting to see, and I look forward to this talk.
And, thank you both. I really appreciate it. Very kind introductions, Sushil and Dr. Kapadi. And Sushil, really excellent talks and wonderful insights into how to avoid these complications, most importantly. So my talk is not actually going to have very much data, but the point is to discuss some of the technical considerations of using the MitraClip in degenerative MR. So what I want to do is just provide a brief orientation to the newest generation of the MitraClip, the G4 design, provide some case examples to illustrate some of these technical details in the treatment of DMR. And really, I hope you appreciate the importance of contemporary TE imaging And in this regard, really, I give, of course, all of the credit to our procedural imaging colleagues. So previously, all we had was the single mitral clip, which is essentially the mitral clip NT in the top left here. And currently, we have 4 different clips from which to choose. The NT comes in regular width and wide width, which is about 50% wider in the grasping area. And the XT is a longer clip. It grasps approximately 3 millimeters more of the leaflet. So especially in the degenerative MR cases, we're most often using the XT or the XTW to really stabilize the leaflet pathology that we encounter. In the newest iteration of the device, the G4, which is being rolled out to different centers in the United States now, and of course also available in Europe and outside of the US, we can grasp the leaflets independently. So you can grasp just anterior or just posterior, and then grasp the other leaflet, which, as you'll see in some of these cases, I think is a very important procedural advance. So the first case, this is a 77-year-old patient with a prior mechanical aortic valve replacement, atrial fibrillation, a CRT in place due to previously depressed ejection fraction. STS score is very high here, 11.4%, demonstrating a high risk for cardiac surgery. In the US, we only treat patients who are at a high or extreme risk for cardiac surgery with a mitral clip, just because surgical repair is so excellent and so safe. So you can see here, ejection fraction is relatively normal, but with severe mitral regurgitation. And you also see severe tricuspid valve regurgitation near the right ventricular pacing lead. So when you look on 3D echo, which all of our patients have as part of the analysis, you can appreciate here, if you look at the imaging plane in the 3D in the bottom right in green, and then you go up to the top left, which is the green box, you see that segment of A2 flail and a very retracted P2 segment of the posterior leaflet there. But what really you should appreciate is how granular detail you can get with this 3D multiplanar reconstruction imaging. So we brought the patient for a mitral clip, and we used the XTW clip. Again, we think that the XT is very helpful in really grabbing a lot of leaflet to help stabilize the degenerative pathology. The wide clip, I think, also beneficial to really make sure you have a good seal of the valve, and not really a significant difference in creating a gradient, whether you use the narrow clip or the wide clip. So you can appreciate in this first grasp, while the leaflets are nicely gripped there, what you see is that we're just a little bit medial of that retracted posterior leaflet that I pointed out in the first imaging. And as a result, if you look at the color flow, I'm sorry that that's not playing very well. I'll try to go back to that. So if you look at the color flow imaging here, you can see that there's a leak just lateral to where we have grasped the clip. And so again, this type of granular detail with the imaging allows you to be a bit more precise. So what we can do is just clockwise this clip a little bit, swing it posteriorly, because again, the current generation of the clip allows us to grasp the posterior and the anterior leaflet separately. So you can see here that we have really taken a big bite out of the posterior leaflet there. And then once we look at the color, there's really no mitral regurgitation left. So even though the initial result was passable, we of course want to be as good as we can in treating these patients. As I mentioned, this patient also has severe tricuspid valve regurgitation. You can see here that the tricuspid regurgitation origin is just between the posterior and the septal leaflets, just in front of where that right ventricular pacemaking lead is. So you can see here in the 3D MPR imaging, if you look especially at the top right box, that our clip is straddling the posterior and septal leaflets just in front of the lead that's bouncing behind it in the commissure there. And once we have grasped the leaflets, we've created a nice bridge between those two leaflets and really sort of a trivial residual tricuspid regurgitation. The second case, this is a patient who had a prior mitral valve ring, partial ring repair a number of years ago, who developed acute shortness of breath. And what you can appreciate here, if I can play this, I'm sorry that these are a little bit clunky. So you can appreciate that there is now a posterior leaflet flailing, and that posterior flail is all the way out at the corner in the P1 segment. If you can see in the bottom box of the 3D, that green imaging plane is all the way out in the A1 P1 territory. And that's resulting in this very severe anteriorly directed mitral regurgitation. So many years ago, we wouldn't even consider to treat a patient like this with a mitral clip, just because imaging would have been difficult with the prior ring. Getting out to the commissure would have been difficult in terms of navigating without the appropriate imaging guidance. But again, nowadays, as you can see here, this is really like doing just any other case. And so you can see very nicely with that imaging plane in the bottom right box in the green across the A1 P1 segment, that allows us to very nicely visualize the pathologic posterior leaflet that we want to grasp. Our clip is aligned in exactly that orientation and location. And then once we've gone into the ventricle and grasped the leaflets, as you can see here, a very nice final result, really trivial residual regurgitation. And because it's so far in the corner, the risk that we run in treating these patients with a prior mitral repair of creating mitral stenosis, again, because the clip is so far in the corner, this patient had a mean gradient of 3 millimeters at the end of this case. This is a patient, an 86-year-old, and you can appreciate here, again, flailing of the P2 segment of the mitral valve, and you can appreciate the annular calcium that's there as a shelf underneath the valve and extending down into the posterior subvalvular apparatus. She has, of course, severe mitral valve regurgitation and starting with a mean gradient of 2. So we chose to use the shorter clip here, the NT clip, even though this is a degenerative MR, because we were worried about causing more mitral valve stenosis, given that posterior calcification and the fact that this is a relatively small orifice, as you see in 3D. So instead of using the XT clip that I said that we usually use for DMR cases, we decided to use the NT. We use the wide version, the NTW, again, just to try to settle down the pathologic leaflet a little bit better. You can see here the valve grasped in the middle in the A2 P2 segment as we had planned, both anterior and posterior leaflets sitting nicely and seemingly well grasped by the clip, with really a residual degree of mitral regurgitation that is trivial. You can appreciate here fluoroscopically that the clip is very stable. You can see the annular calcification there, again, fluoroscopically. The reason that I point out this case, and really to show how stable this clip is that 6 weeks later, this poor lady, she was walking from outside into her house and she fell and her chest hit the threshold of the door and she became acutely short of breath. She was, of course, evaluated in her local hospital, didn't have a pneumothorax, did have a slight rib fracture, but ultimately her shortness of breath continued. And you can see here her echocardiogram shows that the mitral clip had become detached from her fall and her chest trauma, and now it's sitting only attached to the anterior leaflet. As a result, of course, you see the significant regurgitant mitral jet there just next to that mitral clip that has detached. So we brought her back, and again, this kind of a procedure is really something that is far more suitable to do once you have this kind of granular imaging from your imaging colleagues. You can see here the green imaging plane in the bottom right box is placed just immediately lateral to that clip that's flailing around, and there are nice leaflets there to grab. You can appreciate again here that this clip is just exactly lateral to the first clip that is flailing around. And then once that leaflet is grabbed there, again, a nice resolution of our MR, really trivial MR there. I should point out we use an XT clip here, just again, because she had that issue with the NT detaching previously. And you can see now the two clips are really very close to one another. And that second clip is stabilized, the first clip that was flailing. I'll close out with a case that's a bit atypical, certainly. This is an 89-year-old. You can see here severe MR. I think what you can appreciate in this view is that the regurgitation is really very, very lateral in the valve. By 3D, you can appreciate that the A1 segment of the anterior leaflet is prolapsing and flailing, And what I'd really like you to look at is in the very lateral commissure, you can appreciate that there's still leaflet flail there. So it's really all the way out into the commissure that the leaflet is pathologic. So we placed one clip sort of in the medial most aspect of that A1 flail to stabilize it. This is a second mitra clip XTR that is going between that clip and a bit more laterally. So again, we have two clips here, and yet there remains that significant MR all the way out laterally in the commissure because of A1 leaflet was flailing all the way there. Unfortunately, though, what you can appreciate is that there's really no posterior leaflet tissue there to grab. And so this is not a situation where we could put a clip dealing with all of the MR. So what we did was we decided to place a plug between the lateral commissure and the clips that we had placed. So you can see here using an Agilis steerable guide catheter, a stiff angle glide wire that is advanced between the lateral most clip and the lateral commissure. So that wire is sitting there. We then advance that wire all the way out to the descending aorta, so we have some support. There's a torque view guide catheter in the ventricle, and then here you see an AVP2 14mm device sitting there in that remaining hole. Nice 3D echo image of the same, and that has really quelled that MR to trivial degree left. So to conclude, DMR I think can be well treated with the mitra clip. The current generation device really provides the benefit of different clip lengths and widths, independent grasping of the anterior and posterior leaflets, as I showed you in that second case especially. In our experience in treating DMR, we primarily use the XTW and XTR clips. Dr. Kapadia is going to talk shortly about how we use the clips in the functional mitral regurgitation patients. And I think what is hopefully most clear from this talk is that high quality imaging is imperative to achieving a successful result in these cases. Thank you very much.
Thank you very much, Amar. Excellent talk. And as usual, you're a fluent speaker. You literally engaged the audience in your talk. And it was so smooth and nice.
Thank you, Dr.
Absolutely enlightened to hear you. Enlightened to hear you. Miss you. Your talk is really good. Excellent talk you gave. And you showed a number of good cases, particularly that lady who fell down and came back with the dislodged mitral clip, and then you refixed it. So it was great case to see. I mean, we can imagine that that can happen in a patient who has chest trauma if they have a mitral clip. Great.
Thank you, Dr. Bang. I appreciate it.
Thank you. Dr. Samir Kapadia? Hello. Dr. Samir Kapadia? Hello.
I wonder if he may be muted.
No, I'm here. I'm sorry. Our outstanding presentation, and sorry about that. I was muted. You're right.
Yeah. So let me invite you to speak on the mitral clip procedure in a patient of FMR, functional mitral regurgitation. And I will let Amar introduce you again this time.
Sure. So my pleasure, of course, to introduce Dr. Samir Kapadia. He's our chairman of cardiovascular medicine. But more importantly to me, he's been my closest friend and mentor. Any of the things that I showed you in the last presentation are all because of the mentorship and teaching I've gotten from him. Really extraordinary operator, extraordinary academician, and extraordinary mentor, not just to me, but to our whole department. So I think all of us have a lot to learn from the talk that he'll give us on functional mitral valve regurgitation.
And what I found is he's an excellent human being, very approachable and very easy to go along with. I mean, very amazing that you are sitting as a chairman of chairman of cardiovascular medicine in Cleveland, and you keep so much down to earth. It's amazing, and I'm really pleased to meet you.
And thank you all very much. By the way, all our success is because of the outstanding talents we have, including, Amar is leading
Amar
our
is
whole
one of the,
path lab.
yes.
Yeah. So let us just start with this presentation. Thank you again for very kind introduction. So the functional MR. So what I'm planning to do in next 10 minutes or so is to just give you a little bit of a highlight that when to treat and how to treat functional MR. So the functional MR, the most important question about the functional MR is that functional MR is a heart failure management. So just keep that in mind, that you are going to treat not mitral regurgitation, but the patient with heart failure. And if you're going to treat the patient with heart failure, you have to treat underlying problems. And underlying problems include atrial fibrillation, conduction abnormality, meaning that if you have a wide QRS complex, you want to do resynchronization. Coronary artery disease, if they have coronary artery disease, treat coronary artery disease. And optimal medical treatment. And optimal medical treatment these days includes all the 4 pillars of medical treatment, including the ARNI, the beta blockers, the spironolactone, and in my mind also appropriate use of diuretics. So it's very, very important that you have all these elements covered with your treatment. And then the last part is that if you still have symptomatic MR, then treat it. What are the different types of FMR? So this is a little busy slide, but I just want to keep you posted to say that the mitral valve is part of the mitral valve comes from the atrium, then there is an annulus, then there is the leaflet, then there are the cords, and then there is papillary muscle. So you have to understand when you're seeing the patient for percutaneous treatment of mitral valve, that where is the problem? Is it in the annulus? Is it in the leaflets? Is it in the cords, papillary muscles? And especially the annulus, that annulus also contracts in 3 different ways: anterior-posteriorly, the height, the saddle, the translational motion. All of these things has to be analyzed accurately to understand where the problem is. And so this is a good article in New England Journal by Dr. Pat O'Gara. He says that the secondary mitral regurgitation is disease of left ventricle and left atrium. I don't like this or, so I said that it is the and or left atrium, and or it's not just the atrium and the ventricle, but also the mitral annulus. And there is some evidence to say that when the mitral annulus enlarges, many times the leaflet get longer and broader. So if you don't have adequate compensation of the mitral valve leaflets, then the mitral valve leaks. So this is a more pathologically important information to keep in mind when you're seeing the patient. Clinical significance is very crucial. So when you're seeing the severity of MR, understand the severity of MR, LA dysfunction, and LV dysfunction. If you have severe MR and less LA and LV dysfunction, you are golden. You treat the MR and you'll feel better. If you have severe MR, but the LA is dysfunctional, LV is dysfunctional, but not tremendously, then you're still okay. But if you are less MR and LV and LA are dysfunctional, then treating the mitral regurgitation may not help you with the symptoms. So this is an important information, and these are the differences that you see, that this concept of disproportionate MR comes from this idea that if your MR is worse and LV and diastolic volume is not that bad, that means that the MR is disproportionate, meaning MR is more than what you would expect from the LV dysfunction. And those MR is treated better with MitraClip. And then finally, you need to learn that how severe is the MR. Now, this is crucial. It sounds easy to say that you know how severe is the MR, but many times in functional mitral regurgitation is not that easy to understand, because people can be decompensated, the MR can be worse. Good document to say that it is not just one thing. So EROA is not the only thing, but you look at several different things to understand. In my mind, severity, judging the severity is an art. And so I put it like this to say that you have to have a history of the patient, so how bad the symptoms are happening. And that is what is very important to determine that what is the history, the anatomy of the leaflets, then the Doppler, then the LA, LV, and the RV's function and the size, And then, of course, the response to the treatment. So all of these things are important to determine how severe is the MR and what is the real cause of them. And so now the treatment options. So treatment options, as you know, tremendous treatment options, but all of these things have to be corrected. The clip does help very similarly, but unless you have treated them with all the proper medical therapy, it is very, very difficult to use this. So surgery is not a good treatment for the functional mitral regurgitation because there is no data to say that you want to send patients to surgery for functional mitral regurgitation. That's why it's class 2B indication level C. What do we have now? So of course, as Amar pointed out, that we have MitraClip, which is the only approved device, but there is indirect annuloplasty with Carillon. The Pascal is similar to MitraClip, TMVR, several different valve replacement options available, all in trials. And there is a direct and indirect annuloplasty available. And huge investment in that. Amar talked about this, I'm not going to, but there are 2 different clips that are available in 2 different sizes. So there are totally 4 different types of clips that are available. And the 2 trials that you should know for functional mitral regurgitation, the COAP trial that we did in the United States and the MITRA-FR trial that was done in France. And both the trials show different results. In the COAP trial, there was a significant benefit. MITRA-FR, there was no benefit. And the main reason why there is a difference is related to patient selection, the operator experience, and more than anything else, also sometimes the results of the MitraClip itself. So I want to show you one case to illustrate the complexity of how we treat FMR. And I'm just going to show you one case so that we can discuss a little bit. So this is a 68-year-old man. So this is typical that this is a person with multivessel coronary artery disease, has multiple angioplasties, he's doing well, but he has now shortness of breath. He has a single chamber ICD, but he's not being paced, renal insufficiency, severe MR, paroxysmal AFib. And if you look at this, you see this, the MR. Now, one of the things to understand when you're doing a transthoracic echo is that you can do a 4-chamber view and you can do a long axis view. But the better view to assess the breadth of the MR is to do a 2-chamber view. So 2-chamber view is intercommissural view. So this view is very important to say how broad is the MR. So keep that in mind because most of the echoes that we see do not have a 2-chamber view with a good color. So this is an important thing to keep in mind. Then the second thing, I'm sorry about that. Then the second thing is the 3D imaging. As Amar pointed out, this is one of the most important things in degenerative as well as in functional. Functional more so important because we really don't know what is the exact cause of mitral regurgitation. So in order to understand the exact reasoning, you want to see the anterior leaflet, you want to see the posterior leaflet. Posterior leaflet, as you know, is P1, P2, and P3, has these 3 different clefts or 3 different scallops. And so these days we call it cleft, but they're not really clefts because in systole, they're closed. But when they open in diastole, you see that they are really the different types of scallops. Now, here you see that how they come together. So if you can imagine that if you put a clip, how these scallops will open or close depending on how much you pull the posterior leaflet. And also, it is very important to see the ventricular side of the valve. So this is the ventricular side of the valve. So again, you can see that the anterior leaflet, where the cords are connected to the leaflet and how the valve is closing and it's open in the middle. There are several different ways that you can now study the details. And this is very important to keep in mind that you can study the details of the valve with different kinds of imaging, the glass view or this kind of a light view to understand where the valves are attached. The MPR, the multiplanar reconstruction that Amar pointed out, is very, very important. So here you see that the 3D image, and this is the green plane. So you can imagine that if you're going to put a clip on the green plane, this is the green plane. So this is how the posterior leaflet is. This is the length of posterior leaflet. This is the length of anterior leaflet. If you put a larger clip, you will move the coaptation line backwards, meaning that if you put an XT or XTW, you will move it back. And so you will tug on the anterior leaflet back. This might be helpful because if you do that, it might be able to close these clefts. Another way is that you can put a clip like this and clip like this, or you can put two clips together. So there are several different ways you can plan the clip. And in order to plan the clip, you have to understand the orifice area. You have to understand that how the leaflets will come together. And this also view shows you how the opening is in the mitral valve when it is not closing properly. So many times people, and we also use NTR, the smaller clip for the functional mitral regurgitation, but sometimes also putting a larger clip makes sense to bring the anterior leaflet backwards. The characteristics of the leaflet, the size of the annulus, how much is the coaptation depth, meaning that how much the leaflets touch each other, are all very important to decide what size clip to use and how much leaflet you will be able to grasp. So you need to have at least a centimeter worth of a posterior leaflet in order to have a larger clip. And then you plan to put the clip. You can put one clip or two clips, and you will plan it that if you're going to put two clips, how close they are, how parallel they are, because sometimes we want to put it parallel and sometimes we want to cant it depending on how broad is the MR and how we are going to bring the leaflets together. And see here, you can see that this is the two-chamber view I was talking about, that it leaks that much. And then if you put the clips, you can see two clips in the two-chamber view, and there is no mitral regurgitation. And here again, you can see that this is how it looks at the end, where there is no mitral regurgitation. When you put a second clip, it is also very important to understand that how you put a second clip. So the second clip can be placed fluoroscopically. So again, you want to align the angle of the clip to the angle of the previous clip. So you want to turn the clip in such a way that it is not canted. And then you want to have the trajectory of the clip parallel to the prior clip so that you have the same amount of sheath inside, same amount of M knob, so that you are coming at the same trajectory as the other clip. And sometimes you need two views. So RAO and LAO view, both are necessary to determine that how the clip is turned, as well as how the clip is being advanced parallel to the other clip. And how close you come, again, depends on where you want to do the clip and how the leaflets have come together. So it is very important to also recognize that in functional mitral regurgitation, sometimes it is not a great idea to come super close because the leaflets may be coming parallel to each other, so you can knock it out when you try to come super close, or there may be cords next to each other. So as long as you're parallel and as long as you cover, and again, how much mitral stenosis is happening, you can decide where exactly you need to put the clip in the next one. But the close and parallel typically is a better idea rather than not. I'm sorry, it jumped one slide. For some reason it kicked me out. So the take-home message that I want to have, very similar to what Amar was alluding to at the end, that we want to have, I go to the last slide. Sorry about that. So the overall message is that you need to have a wonderful imaging group to help you. You need to have a proper assessment of the anatomy, and you want to manage these things as closely as possible with excellent imaging. When you analyze the result, you want to analyze the result not just in the atrium, but also in the ventricle. You can use different lighting techniques or things like that to assess the insertion of the leaflets, where the hole is, how much is leaking, and you see that you see a little bit of a leak laterally in the ventricular side. So these are all very, very important information to have, but this is outstanding result of a clip with a trivial mitral regurgitation at the end. Again, yeah, as long as you have a proper imaging and anatomy and proper selection of the patient, patients will live longer and even feel better. So thank you for your attention.
Thank you very much for excellent talk and very good example, and the fact that you suggested that GDMT, that is guideline directed medical therapy, along with the MitraClip and also treatment of CAD and also the blocks, if they are there, CRT may be considered in those patients, and they do well with all this in combination. So you need to
Exactly.
look at, so you need to look at the patient as a whole and see what problems he has and where does he fit for MitraClip in FMR, especially. And of
Correct. And
course,
go ahead.
yeah, please.
No, I was just saying that I know that we are a little bit beyond the time. So whatever questions you have, we can answer.
We have 15 minutes. We have 15 minutes to discuss still.
Okay.
And
Wonderful.
not a problem. So it will be a good discussion. That's why I thought that we should go on to have some discussion on this particular aspect, taking into consideration in India, of course, we have also come long way in terms of TAVI, but in terms of MitraClip, we are just beginner, maybe we can say. Few centers are doing MitraClip in India, but it's a great promise, definitely for FMR and DMR both, and need to be considered for a given patient. And that was a difference. You were talking about the difference between MITRA-FR and the COAP trial. And those differences are very important because one gave negative result and other gave the positive result. The difference
You're absolutely right. So
yeah.
I want to say two things for you. So one thing is that remember the TAVR is a technique where we are emulating surgery in the sense that we have a valve that is a problem, and we know that with surgery, when you put a new valve, it cures the problem. MitraClip, although the Alfieri stitch has a surgical background, it is not a common surgical technique of repairing the valve. What we are trying to do is something quite different than we have ever done with surgery. This is a technique that works amazingly well, but at the same time, proper selection of the patient and the anatomy and understanding that this is the right therapy is not easy. For DMR, in my mind, it is easier because at least you see that the valve is a problem, where exactly is leaking. FMR is a little bit trickier because, as you point out, that medical therapy, CRT, all these things are there. Patient is short of breath. And when you really put the clip, sometimes you can get the mitral valve looking even worse than what you started. Because, you know, how you tuck the valve, how you put the clip. And so the imaging person is, I tell people that as an interventionalist, you have to be an outstanding imager. Like as Amar pointed out with all these slides, that how much careful attention of the detail is necessary for an interventionalist. You know, you cannot ask your imager all the time to say that should I turn it clockwise or counterclockwise. You need to understand that how you're going to put the clip, of course, working with the imager, because if they cannot show you all the images, this is, so they also need to understand the procedure and you need to understand the imaging in order to technically do the procedure. But I think technical part is 10% of the part. 90% of the part is selecting the right patient. And that's where I think the COAPT and MITRA-FR were different. That, you know, the secondary MR can be a tertiary MR. And so these are all the good discussion points to say that when you're starting a MitraClip program, you have to have a heart failure group of doctors. Because see, I may be wrong, but in India, many times the heart failure specialty is by general cardiology, group of cardiologists. And it is considered, it is of course very important, but it is not the prime focus. So we want to make heart failure specialty a prime focus, because without heart failure expertise, you really cannot, and it's not to be under, you know, yesterday we had a MVARC meeting and there was 4 hours worth of discussion on just saying that how we are, how long the medical treatment has to be considered before you say that it is failed or not failed, what dose is, whether the doses matter or not. So bottom line is the beta blocker treatment has to be somewhat time dependent and dose dependent. ARNI is not that time dependent, but still not that dose dependent, but still time dependent. And the spironolactone inhibitors have to be there. And diuretics is the least important of all in the sense of the dose, but it is also very important to make sure that patients are not decompensated when you evaluate them, because once you compensate the patients, they may not have mitral regurgitation. So this is a message from me to say that I think we should have a very careful look at the patient in total, not one-time assessment. One-time assessment is a bad idea. So if somebody comes to us and say that, okay, do you need a clip or not? Seeing them one time is not enough. You got to follow the patient, understand the time course, and then make a decision, which is going to be the most important thing. Amar, if you have.
Amar, do you have anything to put in?
No, I certainly agree with that commentary, of course, and especially the importance of kind of properly assessing the non-mitral therapies, medical therapy, cardiac resynchronization therapy, if a wide QRS and so forth, before getting to the mitral valve.
Correct. And Samir, where do you put SGLT2, EMPA and DAPA in the management of heart failure? Are you considering in your center as a prime therapy?
Class one indication. When I said the 4 pillars, I didn't mention the SGLT inhibitors.
That's why I particularly ask you this.
Right. No, you're absolutely correct. And again, only one dose. So this is a class 1 indication, and it is going to be in the new guidelines, class 1A indication. So I think it is very, very important that you put them in the mix of heart failure. It's hard to say how long you wait after the treatment. So with Milton Packer yesterday, we had this discussion, and a lot of good heart failure doctors to say that how long you should wait, because in the clinical trials, it's very difficult to enroll patients if you're going to say wait for 3 months to see the response. But at the same time, it takes that much time to see the response of medication. So sometimes it is better to wait.
Correct, but all the time we
Shomir, I have got a question to Shomir.
Just one
from Kolkata.
Let me complete this.
Yeah.
I'll come back to you. So we have this, SGLT2 I'm coming back to. Initially we thought it's meant for diabetic and heart failure, but now it is non-diabetic and heart failure also.
Correct.
So so much of expansion in the overall the details is amazing. I mean, do you see that in your practice?
Oh, we do, and I cannot agree more that it is now becoming a treatment for non-diabetic patients. Yeah, absolutely. So this is what, and even the patients with preserved ejection fraction. So some of our cardiologists are very, so this is why I say that heart failure expertise is not to be underestimated.
A specialized area.
Because the whole area. And so and we are calling it now the interventional heart failure, because remember that Ancora device, the management of the bioventrics. So there's several, even the interatrial shunts. So there is a lot of different things that are happening in interventional heart failure.
Correct.
So I think we should have both heart failure and interventional
I like this
heart
term
failure.
of interventional heart failure.
Right, because this is what it is.
And that is how it will expand in India. If we write this interventional heart failure, then many interventional cardiologists would be interested in coming, because otherwise they get tagged as a medical therapist.
This is what I'm saying. And medical therapy, people consider it as a second class, but in this particular situation, it is first class.
Yes,
it is.
absolutely.
And also remember, that once you put a mitral clip, your future options are not that many, in the sense that you cannot take it out, you cannot put more, you cannot do a valve replacement. So it has to be a very calculated, very, very predetermined, step. It cannot be taken as a minor thing that, hey, let's try this, and if it doesn't work, let's see what happens. This is a bad idea.
Correct. I have one or two technical questions in terms of TAVI. When do you consider valve to be pre-dilated before deploying the valve?
I think if the valve, so when we put the catheter through the valve, one simple thing, when the catheter doesn't go easily, or we have to manipulate not the wire goes easy. Wire, you cross the wire, but now you're putting a pigtail or a AL1 or whatever. And if it doesn't want to cross, that is a tight valve. If your gradient is much more than 60, 70 mean gradient, then it is a tight valve. If you're going to pre-dilate with a smaller balloon, most commonly 20 millimeter, 23 millimeter balloon. But if you normally, we don't pre-dilate, because the pre-dilation has some data to say that it does increase the pacing risk, and it does increase some cerebral embolization, especially if you're not using the sentinel device. The question is that if you have a bicuspid aortic valve, there is some literature to say that maybe pre-dilation helps with how you break the raphe. If you are using certain types of valves, so if you are using like Accurate Neo or valves that are not super strong and self-expanding, then you need to pre-dilate a little bit more aggressively. And sometimes for core valve 2, you may want to pre-dilate it in order to expand it properly. And if you, like Sushil was pointing out, if you have a left main or some question or sizing question, then pre-dilation is a good idea. But in general, 90% of our cases, we are not pre-dilating the valve.
If I understand right, when you have annular calcification, then pre-dilatation may be contraindicated, because then you're likely to cause some.
Not necessarily, no.
Not necessarily.
Not necessarily. No, I don't mind pre-dilating the annular calcified, because many times the calcium is everywhere. So, it is going to be some calcium in the annulus. So that's not a real contraindication, no.
Correct. And another aspect, if you have a lot of calcification in the leaflets particularly, then pre-dilate the valve. These are the two things which are at the moment controversial. So I thought I'll ask you.
No, you're absolutely right. Again, a lot of calcium is a tough measure to follow, that what is lot. So that's why I'm saying that if it's very tight, difficult to cross, is a good idea, or it's a bicuspid with a big calcified raphe, then it is worthwhile pre-dilating it. Otherwise, it is not so much necessary to pre-dilate.
Amar, I have a question for you.
Sure.
After you do a mitral clip, what percentage of patient do you need an ASD closure, and when do you need it?
Yeah, so this is, I think, an important question, and I wouldn't say is necessarily always the most clear, but I would say in our experience, about 5% of the time, maybe, we're closing the ASD. Primarily, it's in patients if they have very significant right ventricular dysfunction. And so we're concerned that the added volume load that comes from the left to right shunting across the septum is going to be a problem for the RV. That's one reason. Secondly, in patients that have a severe tricuspid regurgitation, and so we're worried they'll have right to left shunting and become hypoxic, that's another concern. Most often nowadays, when we fix the mitral valve with a clip, we also fix the tricuspid valve with clips. So this second issue has become less of a problem in more recent times. But even after we put clips on the tricuspid, if we still have TR, or if it's not a good valve to clip the tricuspid, in these cases, still we might have to close the ASD.
Correct. I think anything, Samir, you would like to add to?
No, I agree with Amar that yes, if you look at the literature, by the way, so he's right that when you close it, when you have to close it, that tells you that there's something not good with the patient, because their outcomes are worse, obviously, because they have right RV dysfunction, they have some kind of a badness happening to them. Many times, we are trying to do a study where we want to keep it open by putting a V-Wave device in patients with functional mitral regurgitation. Because remember that if your RV is good and RA pressure is not good, then this may be of help to have a little bit of atrial septal defect, because that will eliminate some of the congestion that you may have, and the LA pressure may be better. So it is, as Amar pointed out, that we have to have it less than 5%, 5% of patients that we use it. And RV and TR are the most important indications, at least in our situation, when we close it. And it also affects the future options. So if you want to put more clips, it makes life more difficult if you close the ASD. So keep that also.
For future mitral clip, it will be difficult. Correct.
Yeah, very
and
difficult.
how often do you need multiple mitral clips, 2 or 3?
Most of the time we do. Most of the time we do, yeah. So single clip is not that common.
Okay.
If you look in things like TVT registry, average clips for patients is 1.6 or 1.7. So most patients are getting at least 2 clips.
Other side, the TR also, functional TR is also a highly there in the clinical arena.
Correct.
And I'm told the tricuspid tracker clip is also coming in short time.
No, we are using it, the tricuspid clip. Amar and I, we both use it quite often, but the problem with the tricuspid valve clipping is that the valve is thinner. It is 3 leaflets. So how you put it in the septal anterior, septal posterior is trickier. Imaging is more difficult. And the annulus is much larger. So when you try to cinch it, it is even more difficult to predict that what will happen. The cords are many. So tricuspid clipping is most certainly as a step that is, after you are very good with mitral clip, then only I would suggest that you try the tricuspid clip, because it is technically definitely much more difficult.
That's so very nice of you. I think wonderful talks and wonderful discussion with both of you. And of course, Sushil Kodali, who was there with us, but he could not be a part of the discussion. But super, we enjoyed it thoroughly, and we learned a lot from both of you. Thank you very much. In our future CMEs, I will certainly think of 2 of you.
Thank you.
Thank you,
And
Dr.
it's
Bhatt.
pleasure to see you, both of you, and being Indian and at that position, it's always proud feeling. Thank you very much. Thank you very much. So we go, one of our friend, just a minute, both of them go. No, Samir is still there. We have Dr. NIC Chairman, Dr. Dhiman Kali, my very good friend. And
good evening to everybody. Shamir, how are you?
I'm great. So good to see you.
We are thinking when we can meet. Now it's severe. In India, the second wave has come as a severe blow.
So
for the last 15 days, it's terrible. How are you?
I'm praying. I'm
Came
praying.
to our meeting, you remember probably.
Of course, I'm praying for the.
Yeah.
So you have some questions to ask, Dr. Kali?
Yeah, I was talking, Bijay, that mitral clip is now in the near future is nowhere. So if we consider the practical situation in India, I was just seeking Dr. Kapadia's comments that how do you feel that if you give a good cocktail of beta blockers, MRAs, as you told, ARNIs in full dosage, diuretics in a small dosage, and now with the SGLT2 inhibitors, whether it should be used in non-diabetic because it's a class 2B indication according to ESC guideline, but you are following that it should be a class 1. I do admit, and I also do concur with you, that even with HEPAF, it should be used more generously because it's really rewarding. So how do you feel that if we give a cocktail, because some of the cases we have seen, and a gentleman, I have forgotten his name, he came from Berlin, one of the labs. He's a heart failure specialist in Germany. So he was telling that with ARNI in full dosage and beta blockers, many of the cases come from functional grade 4 MR to grade 1 MR. Our experience is also similar, but some of the patients do not respond. I really appreciate the slide which you have shown, that LA and LV both dysfunctional along with significant MR. Those are virtually very bad cases. So what is your advice how to judge those group of patients? Because even if somebody can go for this mitral clip implantation in India with, so how do we
I would
plan
say that maximize the heart failure treatment for
and
at least 3 months in Indian perspective. So if after 3 months of a very good meticulous heart failure treatment, meaning that seeing them maybe once a week or once every 15 days, and after 3 months we are not making a progress and they are still having a severe mitral regurgitation as symptoms, and uh, then I think it is an anatomy is feasible, then you do it. I do agree personally that these are not simple decisions to make. So if you can have a team approach to decide that what is the best solution, then that is the correct thing to do. And the patients do feel better. So there's no question that patients do feel better, and this is a great treatment. But it is not as easy as
yeah,
TAVR for sure.
yeah, yeah.
There is one
Thank you.
question from Dr. Milan Chugh. He's a good friend of ours. He's from Ahmedabad. He knows you very well.
I know
And
him too. Yes.
he knows you very well. And he has a question that the many times in India, we see small stature patients coming for the TAVI. And usually femoral artery sizes is very poor. So in that case, which axis do you think will be a safe for Indian scenario?
I agree. I myself, once you get used to the same side access for even small arteries, because remember the catheter that goes in does not really occupy any space. The smaller it won't be, you won't be able to move the catheter, but you don't need to move the catheter. You leave it in the non-coronary cusp and leave it there. The advantage of the same side access in the smaller size patient is also the fact that you can handle the complications much easier, because you don't have to cross over, you don't have to come there, you are just right there and you can do whatever you need to do much faster, much expeditiously and better. So in our cases, when we have a groin artery that is smaller or more complicated, we prefer the same side access rather than the contralateral access. We may have a contralateral access, sometimes the radial access, to put a pigtail just so that we can move the straight flush so that we can move the catheter. But we still have it's the same side access, so that in case there is a complication, we can handle the complication much easier and faster.
Correct. Thank you very much. How often do you use axillary axis or carotid, or for that matter?
5% of times we use the subclavian access. So
Okay.
usually we do it, we are not doing it percutaneously, we are still using surgically.
Okay.
Because we find it more reliable and better. So just a small incision in the subclavian area.
Correct. Thank you very much.
Sorry,
Appreciate
can I
you
ask?
taking out time on the Sunday. And we have Dr. Anirban Chowdhury from UK. And
Ask me the question. Yeah. Go ahead.
Hi, sorry, Samir. Sorry, I'm based in UK. One slightly different question. So it's still quite a regulated technology, with around 5 centers sort of assessing the suitability of these devices. So if you are in an average community, so it's not a university town or university city, so it's a residential area. If you, in that sort of population, if you're based, what do you think is this number of cases you're looking for, both functional as well as degenerative mitral valve, in a million population? So if you serve 1 million or 2 million population, what numbers are you looking at?
So if you're serving about 1 million people, again, the how many are older or not is a very important question.
Yeah.
But if like United States like population, I would say that you probably would have 50 or 70 per year of functional MR patients that you would treat, and maybe 20 or so of deep degenerative mitral regurgitation that you would have. That 50 to 70 could be 150 to 200, depending on the functional one. depending on the proper selection of patients and things like that. But I would say that if you are starting the program and in the beginning, probably that 50 number is a reasonable number. Cleveland is 4 million people. And in Cleveland area, currently, I think, of course, our practice is way outside of Cleveland because people come from everywhere. So I would not consider our practice as a benchmark. But in Cleveland area, patients, I would say, is about about 150 patients from Cleveland area out of 4 million that we do clips a year.
Thank you, because that's the debate we're having, whether we have one center or two centers for the whole of South Wales, which is about 2.5 million. So
one center is good.
One center is better, what I can make out. And it's probably a bit more than I expected. But US always does procedures more than UK. So that
Exactly. So you can even have even lesser number of patients. But one center, if you ask me, South of Wales, one center should be plenty.
Samir, I have one more question from our colleague from Mumbai. And very interesting one, very innovative question he has asked. Can ASD be closed with mitral clip itself?
No, because there are two reasons. One is that mitral clip is $25,000. So you don't want to do that. And the second thing is that typically the ASD is 8 millimeters in, because it is 24 French. So it's 8 millimeters. So it is extremely easy to close with a Gore device or something. So I nowadays use the smallest of the ASD Gore device, which is 27 millimeter Gore device. That is my go-to device now. In the past, I used the 8 millimeter, 10 millimeter Amplatzer device. The advantage of the Gore is that we can go around it a little bit easier in the future if we have to.
Technically simpler.
Simpler to go around it. Putting it, both devices are similar. But I would not put a clip, no, for sure not, because it will tear the septum. It will tear the septum.
The question was asked by Dr. Anil Poddar from Mumbai. He's a very renowned interventional cardiologist.
Of course.
Very good operator.
No, it is an interesting and innovative question. But the idea is that one is expensive and the second is that it will cinch. So there is no, I don't see, but he's right that if you put a clip, maybe it's easier to go around. I have not done it, just to be honest with you.
Correct, because the cost is prohibitive. $25,000.
Definitely more, yeah. In our situation, we do worry about the cost also.
That's right. I mean, everywhere we have to worry about the cost, no doubt about that.
Right.
Okay. Thank you very much. So if you can be there for the ISR session, we will love to have you. And,
I know I have to go though, but thank you again for inviting.
Okay, we'll involve you in more programs with us.
No problem.
Pleasure.
Thank you.
Thank you very much.
Bye.
Clap for it. Okay. Now we have a next session coming. A session is on in-stent restenosis. 10% of all PCI come back with in-stent restenosis, but the amount of coverage it gets in the various academic session is very little. So this time we thought that we would like to cover the clinical outcome, the clinical presentation, the outcome of the ISR treatment, and how to go about with various procedures are available, various techniques are available to treat ISR. And now we have more armamentarium coming up, including the IVL and the laser and the rota, and of course, many other things where we can use this multiple techniques and give a better result in ISR, particularly under expanded stent coming back with the ISR, which is most likely to give tougher time for the cardiologist to pass through and develop a calcification. Then of course CTO is another thing that we come across sometime with ISR. But overall 10% is a large number coming back with the ISR. And earlier when it was BMS, it was more than 30% ISR. So with the DES, current generation DES, the incidence has definitely come down, but NCDR data from America suggests it's 10% at the moment. So it's still large number coming back with the ISR. So we have a first talk from Dr. Johar. Is Dr. Johar there from America? Dr. Johar? I
He's
think
not. He's not there.
he is not there. So let me start with Anirban Chowdhury, our interventional cardiologist from UK. He has a large experience in using various technologies, including the laser, the rota, and IVL. All three, including wherever necessary, optimally to give a good result in ISR. It's not always a stent. Even a DAPE can be considered for ISR. And lately, there is a study which has shown that the left main, if you do a left main PCI bifurcation, usually we have a Achilles heel problem with the left circumflex ostium. It comes back with the ISR. And their comparative study has been done, stent versus 300 patient, stent versus RCT. It's a proper RCT, stent versus DAPE in the Europe. And DAPE gave better result compared to the stent. Regulating stent, regulating balloon gave better result with the than the stent. So with this brief comment, I invite Dr. Anirban Chowdhury. He's an interventional cardiologist from UK. Earlier he was in Australia, and then of course Canada for a short time, and then moved to UK with the NHS, National Health Services.
Thanks, Dr. Banga. I'm just going to share my screen.
Yeah, please.
Can you see my screen?
Yeah, we can see your screen. We can hear you.
Okay. Is that coming out all right?
Yeah, very well.
Okay, good. Thank you.
Thank you.
No, sorry, I haven't been to Australia. I came from Calcutta to UK to Canada back to UK.
Okay. I read somewhere that you were there for a short time?
No, I have had multiple experiences. There's someone with my same name in Mumbai who had some disciplinary issues. One of my patients went to my clinical director saying, is he the same guy or not? So, so yeah, I've had multiple experiences, but no, I haven't had the pleasure of going to it. And thank you. Thanks for inviting me. It's great to be part of this. And good to see Dr. Dhimal as well. I met Kahali and briefly met him in Calcutta once. You have asked me to talk on management of ISR in the current era and giving a case example. So I'll try to cover both in a brief fashion given the time constraints. So as you have mentioned that, despite the advent of DES, it's still a challenge, stent failure. And it's a different challenge to what we had in the bare metal stent era. So what I'll try to do today is try to briefly touch on the pathophysiology and the mechanisms of ISR, look into various diagnostics tools that we have at our disposal to see how we can deal with these patients better, and suggest a simplistic algorithm how we can approach these patients, and have some examples to to elucidate some of these. So what is ISR? Well, angiographically, it was always defined as greater than 50% luminal area loss, and that's what we call binary restenosis. What is important to remember is when we define stent failure, it's just not the stent, but also the proximal and the distal 5 millimeters, so-called edge restenosis. So it's 10 millimeters plus the stent is, if you have a problem, that's defined as a stent failure. But over time, we have realized, especially with physiology, that this does not always translate to be a problem if you just have slightly greater than 50% luminal area loss. So what is more accepted nowadays, which used to be called the Meheran classification based on the bare metal stent era, is you need to have the above angiographic appearance, but on top, ideally, you should have at least one of the others, which is symptoms or ECG changes, especially in an ACS presentations, or in a stable situation, at least physiologically proven to be significant. And if you don't have any and you're unclear of the history and the symptoms, difficult to illustrate, then if you have a luminal area of greater than 70% loss, especially ideally by QFR, but nowadays we have moved away and we just entirely base this on physiological assessment in the lab. So it's a bit more defined, and I think it's probably much more appropriate, which gives us an idea of what is an ISR. And even if you do have an ISR, it's various types. It can be focal, which is much easier to treat, or it can be diffuse, proliferative, or occlusive. And the reason that we still should take this into account is depending upon what type of ISR you're treating, your medium to long-term outcomes can be very, very different. So if you see if it's an occlusive ISR from the bare metal stent era, your long-term results of stent patency with subsequent PCI was very, very poor. It's much better nowadays, but still is an area where we can do better potentially. If you then look into various factors, in general, they're divided into 5 different categories: pharmacological, biological, patient, mechanical, and lesions. And some of which are in our control of whether we can affect it, and some of that is not in our control. So what is in our control is the mechanical factors of how we deploy the stent. And it's best to deploy it as correctly as we can the first time around, so we don't come up with an ISR. But if we do, we still have to remember these are the factors which are within our realms of influence to affect. And identifying the lesions, which can lead to ISR or which can lead to a second round of stent failure, and dealing with these lesions appropriately. And that's why if you look into indications of intracoronary imaging, where you have a class 2 indication, majority of those indications are essentially these type of lesions, which are long lesions, small vessels, calcified, bifurcations where you might require 2 stents, CTOs, etc., etc. And there are some patient factors which we can influence as well, like diabetes. We were discussing SGLT2 inhibitors in the last presentation, but that potentially significantly reduces your de novo MI, some of which are related to stent failure. LDL less than 1.4 millimoles. If we can affect some of the patient factors, we should try to do our best to do that so that we are not dealing with this challenging situation. If you look into the pathophysiology of ISR, it's slightly different from what we had historically in the BMS era to what we nowadays have in the drug-eluting stent era. So the BMS was largely a response of the vessel to the injury of vessel preparation and stent implantation. It was mostly a smooth muscle cell proliferation. But in the DES era, it is slightly different. It is more of an inflammatory response, and especially with the first generation DES, it was a hypersensitivity reaction to the polymer and the dose of the drug, which led to delayed endothelialization, and in a way that augmented the deposition of circulating lipids, which caused new atherosclerosis. I'm just trying to touch that in a slightly more detailed fashion here. So what you see in the screen is your response to healing. And it starts off with platelet and fibrin deposition, then moves into more chronic inflammatory responses, and then smooth muscle cell proliferation, finally potentially myofibroblast proliferation from the tunica adventitia, which moves towards your tunica intima. But overall, as a ballpark figure, that healing process takes about 3 months to finish. And that's the reason in the BMS stent era, the peak presentation of ISR was around 3 to 6 months. And it was largely a new intimal proliferation or smooth muscle cell proliferation. And often it was diffuse in characteristics. So when we developed DES, we tried to cover that particular 3 months. And we had a challenge. So I've given some examples of, I would say, later generation stents potentially. And what they have moved towards is moved towards a biodegradable polymer and moved towards a shorter and shorter elution of the drug in a lower dose, so that we just cover those 3 months, and after that, it's more or less a bare metal stent. So if we look into that, which leads essentially to lack of endothelialization and suppression of the smooth muscle cell proliferation, what we have in the DES era is a much later presentation of ISR or stent failure. And it typically peaks between 18 to 24 months and is predominated by new atherosclerosis. So it's a very different process compared to what we had in the bare metal stent era. So when we have a problem with stent failure ISR, how do we go around evaluating it? Well, the simplest is obviously angiogram, but it had its limitations. It can give us an idea whether it's underexpanded stents. It can tell us whether it's a calcium shelf outside, which is resulting in underexpanded stents. If you use technologies like digital subtraction angiography, stent boost, stent enhancements, you can pick up stent fractures at times. You can pick up geographic miss. But that's where we are limited to with regards to just angiogram. So the suggestion nowadays is if you have a stent failure, you always image it intravascular as well. And the reason for that is it gives us an idea of the precise mechanism why the stent has failed and how we can then go around modifying the process which has caused the stent failure, if there is any, or we can then how we can treat the tissue inside the stent. So this goes back to the mechanical factors which I was mentioning. So stent sizing, under deployment, under expansion, geographic miss, stent fracture, etc. What tissue is it? Is it neointimal hyperplasia, like a bare metal stent type? Is it neoatherosclerosis? Is it an edge restenosis, etc., etc.? So these are the bits of information that we gather, and then we go around trying to tailor our therapy, how we manage the ISR patient. But overall, if it's a stable presentation, it's always helpful, unless it's critical, to work out whether it's just a binary restenosis or do we really need to treat this patient. So physiological assessment, especially in the stable patient, is always suggested as the first line. So if you put all these factors together and try to come up with an algorithm, I'm sorry, it's a slightly busy one. And so if you start off at the top, which is stent failure, and if the patient has come in a stable fashion, you decide with physiology whether it requires treatment or not. The answer to that is yes. Or if it's an acute presentation, and you proceed to intravascular imaging one way or the other. And then you decide what's the problem. Is it an underexpanded stent? Is it an undersized stent? Is it an edge problem? And then accordingly, you can decide edge problem most of the time requires a stent. If it's an undersized stent, you can potentially correct that if it's within the limits of expansion of the stent. And if possible, use a drug-eluting balloon. If it's an underexpanded stent, you try to correct the underlying problem with laser, with nowadays lithotripsy, if it's felt to be safe, with rotablation. And then again, if you can use a DEB, that's fantastic. If you can't, then you have to use the stent. You look at the tissue. Was it neointimal hyperplasia or is it a neoatherosclerosis? Modify that with appropriate balloons or laser. And again, you decide how we manage that. So in a way, intravascular imaging has become the cornerstone of how we tailor therapy in these cohort of patients. So as asked, I'll try to present some of my cases that I've come across over time and give various examples. This is a 72-year-old gentleman who had a PCI to the LAD about 3.5 years back. He represented with an NSTEMI with anterolateral changes. And this is what his LAD looked like. There was some disease in the circ, which we have fixed. But can you see the arrow on my screen?
Yes.
Yeah. So the stent was deployed for somewhere here, and it just goes past this small diagonal. And the operator at that point, in fact, had 2 stents. So there's a zone of stent overlap here as well. So there's 2 layers of stent in the middle. And this is, you see the run of OCT. And when you try to work out, to go to the normal area, you have to go quite distal. And as you come a bit more proximally, you start seeing what is this relatively smooth, not entirely smooth, because what is neointimal proliferation. And then you see these zones, which are heterogeneous, which are pools of lipid, which have been deposited. As you come a bit closer, it becomes even more with regards to the amount of deposition of atheroma beyond the neointimal proliferation. And then you come to the stented segment. This is close to the exit of the stent. You can start seeing the stent struts. And again, you see this is neointimal proliferation, but then you start seeing pools of lipid, which is behind the neointima. And then you come to the middle of the stent where you have the 2 layers of stent. You can see the 2 layers, 1 and 2. You have the neointima again, but then you see a very, very well demarcated evidence of neoatherosclerosis, which goes all the way around. You come to the proximal edge of the stent, the same pathology is there as well. And then you come proximal beyond the stented segment, where you do not have a lot of stenosis, but still has a fair amount of atheroma burden. So you gather all this information and you decide how you're going to deal with it. So in this case, first balloon dilatation was performed, and what we had is in this situation is you have an edge dissection beyond the stent, which obviously meant that had to be dealt with. Inside the stent itself, there's relatively well, expansion post POBA, but proximal to the stent, it looks a bit more unhappy. So what we went around is we deployed a stent distal to the stent, going up to the normal segment, because we didn't feel we had a good enough landing zone anywhere in between where we could have landed the stent. We deployed a stent proximal to the pre-existing stent, again connecting a normal segment to the previously stented segment, and the middle of the stent was dealt with a 3 into 30 millimeter drug-eluting balloon in the middle. So edge restenosis dealt with the implantation of new stents, while the ISR itself within the stent could have been dealt with a drug-eluting balloon. And this was what the final result was. So normally we try to avoid going that far down into the lead if we can, but just the way the whole procedure evolved with the edge dissection, with the distribution of the atheroma, that's what was felt was required in this particular patient. So second patient, younger one, treated previously essentially in London. From what I could make out, had a PCI to the left main to LAD, and then after some time had a PCI to the left main into circ, making it essentially into a culotte technique, but then represented in November 18, same hospital, with a severe ISR of the circumflex. As Dr. Bang was saying, it's very commonplace to have ISR in a two-stent technique is a side branch ostium. That was imaged, that was treated with a drug-eluting balloon, and then he's basically in the process of moving to Swansea and South Wales, so he presented to our hospital with the recurrence of his symptoms within 4 months. So I essentially told him before I started that we are going to have the same problem which they found in London, and we have to see how we can deal with it. So he had a non-dominant right, so we just went straight with the guide. So this is what we have. So as expected, we essentially have a failure of the stented segment, which has already once been treated with the drug-eluting balloon. And so we pre-treated it with a 3.5 non-compliant, one inflation 3.5/20 non-compliant balloon. And then this is what we get when you image it. The ostium of the circ, slightly elliptical, as is often the case, with some fibrocalcification around 180 degrees. As we move away and come to the proximal part of the circumflex, you see again that shelf of fibrocalcification on one side. Then you come to the middle of the stented segment, and this is a classical appearance in high definition IVUS, where you have this appearance of neointima and neoatherosclerosis, the heterogeneous appearance that you get on IVUS. And when you go to the normal vessel to get a vessel sizing, this was a 4 millimeter vessel even in the mid circumflex. Okay, so the mechanism of ISR was felt to be mostly neoatheroma progression in an undersized stent. The previous stent was a 3.5 millimeter stent with a degree of underexpansion in the proximal segment because of fibrocalcification. So with that interpretation, what we did was we took a shockwave balloon, and it took us about four pulses to have that balloon fully expanded in the proximal segment. And because this gentleman already had DEB failure, so what we did here was we treated this with implantation of a new, which is now 4 millimeter, but ultra thin strut stents, and then finished the procedure with a kissing balloon, with a drug-eluting balloon essentially in the ostium of the LAD. And this is what the final result was after at the end of the procedure. And again, if you have opened an imaging catheter, it's always good to see whether you have corrected the problem. So this is the ostium of the circumflex, elliptical origin, which is often the case in the origin of most side branches. When you move a couple of millimeters further downstream, you have a much more circular stent with the 2 layers of stent that you can see. Like similarly in the middle of the stent and the distal edge of the stent. So we have managed to correct at least what we felt was the nidus for recurrent stent failure, which is under expansion because of fibrocalcification on one side of the vessel wall. And he has been well for the last 2 years after this PCI. So patient 3, he first admitted in March 2017, and he presented with unstable angina. He already had a history of LAD and RCA PCI in 2011 for an NSTEMI, so he's done pretty well 6 years. And he presented to a center when I was in the University Hospital in Cardiff. And what you find is you have severe ISR, very focal but in the middle of the RCA where you had the stent. So that was dealt with one of my colleagues with angiostop balloons, which is a cutting balloon, and then implantation of a biometric stent, which is a 3 millimeter stent, which was post-dilated with 3.5 millimeter non-compliant balloon. But what you find is this is obviously a little bend, which you would probably better appreciate in our review. There's still a zone of under expansion in that segment where the ISR had taken place. So this was in March 2017. He represented in July, again, exactly with the recurrence of the same symptoms, and again, very borderline high sensitive troponins. And when you repeat the angiogram, you have severe ISR, probably worse than the first time around, exactly at the same spot. So we had 2 layers of metal with the recurring ISR. So what we did, what we went around is this gentleman, we tried to modify the background fibrocalcific segment with a 0.9 millimeter laser catheter. So if you are going to have laser, my advice is just have the 0.9 millimeter. You don't need any other catheters because at times you need the 80 dosage, and that's the only thing you can get is the 0.9. The larger catheters do not allow you to have those pulses. So it's proved a bit, quite long. We had to finally give 9,000 pulses in this case. And this is on the right, you see a 3.5 non-compliant balloon at a very high pressure to modify the lesion as much as we could. We unfortunately had to deploy a third layer of metal because when you deploy that amount of pulses, how much of the stent integrity is slightly compromised, especially in a fibrocalcific lesion, is slightly unclear. So if you could get away with lesser pulses with appropriate modification, a DEB is fantastic. But if you had to have a lot of pulses of laser, at times maybe you have to consider a third layer of metal here, unfortunately. But what we deployed was a 3.5 millimeter stent, which was stretched with a 4 millimeter non-compliant balloon. So we tried to at least correct the underlying mechanism, which was under expansion. And this is what you get an IVUS. So on the left, you essentially find this is after aggressive predilatation before we took the laser. The minimal stent area there was around 6.4 millimeters square. And this is what we have the end at the same spot, which is 9 millimeters square. So despite having 2 layers of metal, laser allowed us to modify the background substrate with nearly a 30% increase of luminal area or minimal stent area. And this gentleman is in fact done very well. He stayed away from us for 4 years since he had this procedure. So patient 4, 74-year-old lady, had bare metal stent PCI in the remote past, came back with angina after 16 years. So he on paper has done exceptionally well after PCI, had a positive MPI, had an angio in the local hospital, and he was referred to us for PCI to his RCA. And this is what you have, and this is not entirely uncommon in with severe bare metal stent ISR. So I don't know how much you can see. You see these 2 black dots here. So that's a carbo stent, which I have not deployed ever in my life, and I started doing cardiology from 2006. But it is one of those bare metal stents which has had carbon, which is felt to be very neutral. So I've seen a few of these come back over the years. So you have the carbo stent in the middle, and you have a stent at the ostium of the RCA. This is an injection through the retrograde microcatheter after we have crossed on the septal. So essentially, you had ostium, the whole RCA from the ostium to the crux, which needed to be revascularized. So we not unexpectedly had difficulty with the antegrade system because of lack of support. You see in the last one, I had a straight tip wire, but we lost catheter position a few times, so I had to knuckle. To balloon to get a guide liner in. So in the process, we landed up going false lumen antegradally. And when he came in retrograde, it was hard to connect the true, because my wire was in the true lumen here and it was a false lumen antegradally. So finally, when I did manage to connect, my wire went through a stent strut and I realized it, but I spent about half an hour trying to connect the two sides. And so I decided to persevere with it. But unfortunately, we couldn't pass any balloons through that stent strut. Again, not unexpectedly. So we were a bit stuck. And so we decided to rotablate this. So normally nowadays we use rotablation only to modify disease. Historically, it was used as a debulking agent. So in this situation, it acted as both. It helped us to debulk both the stented segments, the entire vessel in the middle, and obviously create a channel which allowed me to pass kit now through the stent struts. You image it, and what we realized is the previous stents were grossly undersized, and that is very important because we don't want to have the recurrence of the same problem. So we essentially have occlusive ISR of both the bare metal stents with progression of disease in between the stented segment. And then this is the final result that we had with regards to expansions. I work off mag, so a lot of my images look small because I do even my routine PCI is off mag now. So that's the reason they look a bit smaller than some of the angiograms of others. So this is patient 5. So this is more of an acute presentation, but I just thought it was a good example to see how we can use technology to diagnose a stent failure. So primary PCI to the LAD, and the patient represents within 2 weeks with the recurrence of anterior STEMI. And these are the still images which I've taken, which I felt was easier. So this is the index procedure. You can see a bit of calcium beyond the occlusion site. It was a 2.5 long stent which was deployed. It was nicely post-dilated with a 3 millimeter non-compliant balloon, but the operator felt the vessel wasn't 3 distally, so then had to take a 2.75 balloon for the last part. And the longest balloon here was 8. So he used the same small balloon multiple times to overexpand this area, which had a bit of chalk. And when you take very short balloons and you do multiple overexpansions, it can cause damage to the stent, which over time we have realized. So here, when he comes back after 2 weeks, this is what we get. Blockage of the stent, we have aspirated, and we've got a very good result with regards to TIMI3 flow, but there was this filling defect which just would not go away. And when we do the OCT, the stent is very well opposed, appropriately sized, well opposed in the mid to proximal segment. But in the way we have the filling defect, we had a funny appearance of the stent. So you have these 2 layers of metal, but there's only 1 stent. And this more, luminal side goes nowhere. There's no continuation of that metal. So we post-dilated it to that in that segment, but that appearance filling defects slightly remained. We did another IVUS. Still shows the 2 layers of stent, despite having 1 layer of metal there. And when you have time afterwards, you play with your 3D reconstruction, what we find distally has been multiple fractures in the distal centered segment where you have this calcific shelf. So if you have to post-dilate, it's often better to use a balloon, 1 balloon which covers the segment. If you use a very short balloon and you have to do it multiple times, I think it creates an undue stress on the stented segment, and that can lead to these stent fractures. So if you have a stent fracture, you have to put in another stent. That's what we do. And this is what it looks like after you have put in a second stent. You can see the 2 layers of metal now in multiple places. And this is the final result. So it hasn't come back after 2019. So another patient who again had a primary PCI to the LAD, had bystander disease to the RCA, which was treated as an inpatient stage procedure. So you can see this is a 353 60 millimeter stent, and you can work it out what stent that is because that comes from India. And there's nowhere else you get that length of stent, and it's a good result. It has a good result. I've shown you only an LAO view where it looks nice and smooth and like a C. The patient represented after 6 months and had a focal ISR at one point. And now if you look into RAO, it's not really a smooth straight C, it has a hinge point. And the ISR has happened essentially at the hinge point. So we did an OCT, but there was some emotional rotational deformation because of that rapid movement of the catheter in that particular segment. So it was not entirely easy to interpret what we had in real life. When you sit down and go through the images, screen, one shot after another, you could work out what it was, but in real life it is a bit more tricky. So what we did is, this is another modality, we just did a DSA. So digital subtraction angiography, which is, I'm sure, there in most labs. And what it shows essentially is complete avulsion of the stent where you have the hinge point. So at times, as I was saying, even without the latest or spending more money, at times you can get a diagnosis of stent failure by using the various modalities that you have, like stent boost or stent enhancement, or even a digital subtraction angiography. So we treated that with a cutting balloon and then a short stent to cover that stent fracture, and he has done well for the last 2.5 years. So to summarize, stent failure, despite the advent of the DES era, remains a challenge. And because we do way more PCR than we did in the bare metal stent era, we are seeing patients coming back with stent failure. And we should use whatever tools are required for us to work out why the stent has failed and whether we require treating that binary restenosis in the first place. Once we identify the mechanism of the stent failure, we should try to use the adjunctive devices that are available at our side to work out how we can overcome that problem and then come up with a form of treatment which hopefully will give a better and a durable long-term result. There's been a lot of studies about stent failures from the BMS stent era to even now, and we have reasonably good idea what to do, but it's a very heterogeneous cohort of patients. So in the DES era, proliferative near-occlusive stent failure, does DEB have any role? On the contrary, if you have a focal ISR, should we just use DEB as the first line? So these little bits of information, we probably can do a bit more with either meta-analysis or large registries or even RCTs to see whether we can identify niches of treatment in this cohort of patients. Thank you.
Thank you very much. And we will have a discussion at the end. So I request you to stay along. And I invite our Dr. Rajiv Johar to deliver his talk on clinical presentation and outcome in ISR. Dr. Rajiv Johar is the Chief of Cardiology at North Shore University and Northwell Health, New York. And there are multiple hospitals he's in charge of.
Do you see my screen, Vijay?
Yeah, I see your screen, I see your slides. I can hear you also.
Oh, wow, that's even a positive.
Yes.
You can see my slides, right? Perfect.
Yeah, absolutely.
Dr. Chowdhury, that was a terrific talk, by the way. And you brought up 2 points that are of paramount importance. One is, I think, that in-stent restenosis is not a dead phenomenon. We thought it was going to be over after drug-eluting stents. It's not. It still occurs in several % of patients. Number 2, imaging. It is of paramount importance. You must image. I mean, the number of restenoses I've seen in people who put a 2.5 stent in a proximal LAD, I can count on several hands. And then number 3, the armamentarium we have available to us is so important. Just ballooning and stenting does not always do it. DEB, although we don't have that in the United States for coronary use, Shockwave, which we just released, laser, which I love to use, which I think is so important. But at the end of the day, bigger is better, and bigger precludes you from having restenosis in a higher percentage of patients. So that was a terrific talk. I'm going to sort of talk about one particular niche that I think is very, very important that we don't use across the world, but we've been using a lot in our hospital and some of the hospitals here in the United States. Good morning. I'm Rajiv Johar. I'm the Chief of Cardiology here at North Shore University Hospital at Northwell Health on Long Island, New York. Thank you all for joining on a Sunday. In-stent restenosis was our Achilles heel. It was our Achilles heel for the last 30 years, and we felt in 2003 that it was done. When Ravel and Sirius came out and the percentage of restenosis was initially at 0, we thought that was it was the beginning of the end, and we had overcome restenosis. Well, clearly we have not, and it still occurs in several % of patients. So yes, in BMS, it did occur in 20 to 30% of the time. In DS, it occurs on the average about 7 to 10% of the time. And with all due respect, there's really no truly effective treatment of restenosis except imaging and expansion of the stent. So it does consist of 3 components. We've dealt with elastic recoil with the scaffolding of the stent, but the intimal hyperplasia, the remodeling, and also the late effects are what are the issues. If you look at in-stent restenosis, one of my colleagues always said to me, it's not a big deal. You restenose, you've endothelialized the stent, you do another procedure. It's not a big deal. Well, the reality is it is a big deal, and in-stent restenosis does create other issues, target vessel revascularization, myocardial infarction, and possibly even death at 3 years. So it is not a benign event, and to mitigate it and to minimize it is of paramount importance. I think Dr. Chowdhury said it perfectly. You know, imaging plays such an important role in in understanding the histopathology of in-stent restenosis, whether it's neointimal hyperplasia and homogeneous uniform layer on an OCT, or whether it's neoatherosclerosis, which we see more and more commonly, which everyone defines as restenosis, which really is one of my pet peeves, which really presents as a heterogeneous composition with a necrotic in-stent core. And then the one thing that I see the most of with restenosis is stent under expansion and stent fracture, which is really a big problem. And really one of my pet peeves also is because that just tells me that someone didn't spend the time to image. And I can tell you, you know, being now, I'm 55 years old, I was not a big imager early in my career. I think it was a cumbersome process. The equipment was not that good. Now that most of us have tableside imaging, whether it's OCT or IVUS, regular or high definition, to not image some of these vessels, which we know are higher risk. Dr. Bang mentioned, you know, bifurcation stenting, stenting at the branches, proximal stenting. Those are ones that should definitely be imaged and imaged often. And then this reiterates my point, is that must get imaging prior to management. Because, you know, with OCT, you get to appreciate the multiple layers of stents. You get to appreciate, I think Dr. Chowdhury showed a terrific case of stent fracture, but to appreciate a stent fracture in this patient, which you cannot really see on just angiography. But with imaging, you get to see areas where there is most likely stent fracture and how to manage and deal with these patients. So I'm going to my talk is going to be geared via a clinical presentation. And then the bulk of my talk is going to be on vascular brachytherapy, which we've been doing a lot of recently. And I think we've had some terrific results with some terrific, with some interesting publications. This gentleman, and again, for full disclosure, I had nothing to do with this gentleman until the very end. So how and they proceeded with the angiography and the angioplasty has nothing to do with me. But this gentleman presented to our initially in June of a year, and the time course is very relevant here. It's a 64-year-old gentleman presented with worsening dyspnea on exertion and class 3 angina. Had a history of diabetes, which should cause bells to ring in your head because the risk of restenosis is higher. Had an anterior wall STEMI with a 6 months prior with a proximal LED at 3.5 Promos Premier stent, and has an ICD. Also quit smoking at the time of his myocardial infarction. So in June of that year, you can see the proximal LED stent, which seems that there's no evidence of restenosis, but the proximal edges into the ostium of the LED and the circumflex have significant lesions in them. And again, you see a sort of a proximal / distal left main and a closed right coronary artery. The options for this gentleman were obviously medical therapy was really not a very good option, except that we must do it, but that was not the only option we could prescribe to this patient. CABG versus high risk multi-vessel PCI. Patient adamantly refused CABG, even though his Syntax score was 26. And the thought was to do a Impella with hemodynamic support, for hemodynamic support, and a high risk multi-vessel PCI. So the operator at that time in June decided to do with an Impella, do SKS. Now, if that's, I'm not sure that would be my choice of technique, but irrelevant to the talk. Results were good. Angiographically, imaging was not performed. 3 months later, he was admitted with recurrent anginal symptoms. He was not smoking, was fully compliant with his medications. And again, the LED stent appears angiographically okay, but he clearly has ostial circumflex restenosis. He underwent high pressure ballooning, and was sent home. February, comes back again with chest pain, dyspnea for 7 days, diffuse anterolateral ST depressions. Now he's hypotensive and on pressors, and his wedge was at that time 36. Again, he's got in-stent restenosis. This time he got a second layer of stent. Again, imaging was not performed. And there lies the problem with a couple of problems here. Number one is this gentleman is now restenosed twice. And we've used just basic technologies. What we've done is use the same technologies we've always used for de novo lesions, and assumed that, you know, by repeating the same thing over and over again, it's gonna work one time. Well, you know, when you look at the different causes of restenosis, whether it's focal, diffuse, proliferative, you know, what are the, is it mechanical due to underexpansion or stent fracture where imaging would really help? Is it biological for neoatherosclerosis? Is it a mixed bag, which is most likely? Is it a CTO like Dr. Chowdhury showed a case of? Does it have more than 2 layers of DES, you know? And surgery is not a bad option in some of these patients with proximal disease. But using the right technology for the right pathology is so important in this situation. So what are the options we have available to us? We have, well, I think Dr. Chowdhury showed that perfectly. Medical management is really not a good option. It's a necessary option, but is not cannot be done alone. Pure balloon angioplasty, well, it is done, unfortunately, a lot. And then we get really excited because the angiographic results look okay, but then they invariably come back. Scoring or cutting balloon, atherectomy or ablative device, which I'm a big fan of. I think no matter what technology you use, making sure that you ablate, maximize size is important. DEB balloons, which we don't really have in the United States for coronary restenosis, but I know it is very popular around the world. Repeat DES, just when in doubt, just put another stent in. That doesn't always work. Bioresorbable scaffolding is obviously the initial option, and then vascular brachytherapy. So this gentleman had his acute MI, had a stent, had another stent, had a angiosculpt and a POBA to the ostial circumflex. So he's now got severe recalcitrant refractory in-stent restenosis, despite PROMIS, Resolute stenting. Laser atherectomy was done on one of the restenosis times. What are our treatment options? You know, POBA it again. Is there another round of DES? Maybe try Xience, although I'm not sure how that would work. Drug-eluting balloons, if we transfer the patient to Cardiff or into England for Dr. Chowdhury to do. Cabbage, which I think is a very viable, reasonable option. Brachytherapy is also one of the last resorts we have available to us. And it works on the premise of the cell cycle, and whether it's cytotoxic or cytostatic, radiation works really via the S to the M phase of the cell cycle, where, you know, smooth muscle cell proliferation and neointimal growth occur. The thought process is that, you know, when we looked at the original data with some of the brachytherapies in the DES era, we had some data in the, and we had actually written some of that data in the early pre-DES era, but DES is associated with decreased long-term TLR, but it's not zero. And clearly, you know, DS is the right therapy in most situations, but in the ones that are recalcitrant, where you have restenoses, and there are patients like that, you know, we see it in America, in the African American population, that really have, for lack of a better terminology, keloid formations either on their skin when they cut themselves, and then in the intracoronary lumen when they put foreign objects in their coronary tree, like stents. So what do we have available to us? We have the beta brachytherapy system by Novost. It's really indicated for in-stent restenosis for native coronary arteries. And lesion length is variable up to 60 millimeters. It uses a strontium beta source, and it is only contraindicated if you can't take antiplatelets or anticoagulants for a long term. Ron Waxman presented some data on this in 2016. And just so you know, in the New York market now, we were the first center to have brachytherapy, but now in the New York market, we have 4 centers now that are doing vascular brachytherapy, intravascular brachytherapy. So Ron showed 186 patients who underwent brachytherapy for recurrent DES from a percutaneous registry. The average age was 65, and as suspected, a majority of these patients smoked and were diabetic. What I found fascinating was that the number of previous ISR was 3 to 4 episodes. My rule internally is I give them 2, and then I option of brachytherapy or bypass surgery. I very rarely go, actually I never go to the 3rd or 4th unless the patient is truly symptomatic and absolutely adamant about not going for surgery. And the outcomes at 30 days, the target lesion revascularization was 0.5 to 3.3 to 12.1% at 1 year. And remember, these are the recalcitrant in-stent restenoses. So clearly, you know, these are not the typical classic, you know, patients that don't develop restenosis. But the majority of these patients did get intravascular ultrasound. So you could argue, was it the ultrasound and imaging that helped, as well as the use of adjunctive devices like laser and rotational atherectomy, or was it the vascular brachytherapy? Well, our experience, which we just published for the 2nd time, and I apologize for the slides. They came out a little worse than I would have preferred. But clearly, we looked at 290 patients that underwent brachytherapy, and the large majority of these patients underwent a scoring balloon. A small percentage I had laser atherectomy along with the brachytherapy, but a large majority of them did not get cutting balloons. And you know, in our hospital, among our own faculty, we have a wide array of thoughts about imaging. And then we've had the change of thoughts about imaging over the last several years, as some of us have gotten more and more gray hair. I'm a strong believer that every ISR patient should get imaged, period. And I believe it's almost malpractice not to do it. But a lot of my other colleagues were not imaging and were just performing the brachytherapy without imaging. And if you look at it, the in-stent restenosis were very similar to what we found with Ron Waxman's study from Washington, D.C., that at 1 year, 290 patients, in-stent restenosis were occurred in about 12%. Again, the recalcitrant patients who were getting in-stent restenosis. And these patients were treated long-term with intravascular, long-term with antiplatelet therapy. So with intravascular brachytherapy, what are some of the adverse effects? Well, late thrombotic occlusion, because you are really preventing, in some situations, if there's a newer stent, some endothelialization. You can have edge effect, or what we call a candy wrapper effect, which clearly can be an issue. Here, if you see the stent edge, which clearly has a candy wrapper effect, which is at the edge of the radiation zone, which can be problematic. So we've now expanded our radiation zone to several millimeters margin at both sides of where we do the brachytherapy to mitigate geographic miss in these patients. And the mechanism of this could be paradoxical neointimal hyperproliferation or constrictive remodeling in these situations. So what do we do on this gentleman? Well, he finally came to us. And if you look between the two markers, we have the strontium 90. He underwent brachytherapy with, and I repeat, with imaging. This is the final result. There's clearly some in-stent restenosis there's some narrowing at the proximal LAD. The circumflex looks angiographically good. We had expanded it maximally with intravascular ultrasound. 8 months later, he came in with this vague chest pain, and because we were so in tune with his restenosis, we actually brought him back to the cardiac catheterization laboratory and did an angiogram, and clearly the circumflex did not have any significant restenosis. So what are our proposed treatment algorithms? Well, and I think Dr. Chowdhury showed this very nicely, but with bare metal ISR, which is now really passé, DES, although the use of bare metals in the United States is still running about 2 or 3%. So in the situation the patient needs surgery, patient can't tolerate anticoagulation. But I think, as our antiplatelet agent length of therapy decreases now down to essentially 4 weeks, they're becoming less and less frequent. In-stent restenosis, I give them one restenosis with another stent or aggressive ablative therapy, and then I go to VBT. If it's recurrent DES, instead I go directly to vascular brachytherapy or CABG. I do not put a third layer stent in. I don't think I put a third layer stent in the last several years in these patients. Stent sandwiching, in my personal opinion, does not work. Incidence of DES ISR can range really anywhere from 3 to 20%, with a sweet spot around 8 to 10%, 7 to 10%. Imaging is, as everyone stated so far, is extremely important. And brachytherapy should be and is useful in our armamentarium, along with all the other therapies that Dr. Chowdhury and others will talk about. So I think this is a very good technology that if used in the right situation would be very, very beneficial. I thank you for your time. I will
Thank you
stop.
very much, Dr. Johar. Excellent presentation, very good cases. And yes, of course, the brachytherapy reemerged. At one time, we remember that brachytherapy was not considered as popular as in the first phase. But when it started, the reuse of this brachytherapy in the second phase, it has reemerged, particularly in ISR. And I think
is it being done in India, Vijay?
We used to have brachytherapy in India, but now no more, because phase 1, we had a lot of failure with brachytherapy. Right. So maybe that that time, whatever cases we have used may not have been a very appropriate cases, because BMS era. I'm talking of BMS era.
Right, and I think Vijay, the beta source is where I think there's some clear benefit, because you can be in the room. The other sources previously, required everyone to leave the room, it was cumbersome. It was probably not done in the right situation.
Yeah,
And,
yeah.
you know, now there's definitely a resurgence in the United States. And so it's an interesting concept. And again, it is not to be used in every patient. It's to be used in recalcitrant restenosis. Dr. Chowdhury, do you use it in England at all?
No, I've never been exposed to brachytherapy. In fact, I spent a year in Toronto, which I think historically used to use it.
Yes, they did.
Because the youngest consultant there, his PhD was in brachytherapy, but I didn't see a single one being used. But as you have said, and as I was saying, is, you know, in the beginning of 2000, when we had DES, we thought this is all gone. And now obviously, you know, we have a different type of problem, more PCI. So we are going to have stent failure, and we have to look into whatever we can use, you know, for these. I was looking at your data, 3 years, 20% TLR. It looks 20%, but the other way to look into is 80% is not coming back. Yeah. And these are very, very difficult cohort of patients to treat. You know, so yeah, it's probably, you know, I guess some centers will end up revisiting this. And if they had the facility before, probably have it back again.
You know what's interesting, you know, just from a geographical perspective, we were the first site to do it in the New York area. And, you know, it was interesting because, you know, it's such a competitive market. And yet my colleagues from other centers were sending me procedures to do because they saw its value when their patients came back to see them. And then they realized very quickly, you know what, why should we send it to Northwell? Let's do our own. And so now we've had 1, 2, 3, 4 sites now open up shop in the last couple of years, and they are all exceedingly busy. Again, in the right situation.
Yeah. So, so when do you consider, Rajiv, the brachytherapy in ISR as particular subset?
Yeah, you know,
after the imaging.
Right. So, like I showed in that case, you know, the first restenosis, we do not do brachytherapy. I think that's wrong. The first restenosis, we honestly, the majority of cases that we've found are, a lot of them are self-induced, which is that they're under expanded stents. I would argue, and this is anecdotal data from my own experience, is that a lot of the restenosis we see in the DS era are under expanded stents. And so once we fix that with imaging and really, you know, either put another second stent in or blow the hell out of that balloon or that stent, a lot of them do not come back. If they come back a second time, and then I consider it to be more recalcitrant, and that's when we think of brachytherapy. Now remember, brachytherapy is a very cumbersome, very bulky catheter, and so, you know, if you have an OM2 lesion and you have restenosis in the 2-5 vessel, that catheter may not reach that area. So really, it's very useful for larger vessels. I have done it in 2-5 vessels, but in general, it's 3 and 3-5, and more proximal or mid lesions, not distal.
Have you used it in these LCX ostium in a patient who have used it?
That was the case I just showed you.
Yeah, yeah, correct. But do you use them regularly because now Lettman bifurcation stenting is a common procedure in most cath labs?
Yes, we do, and we have. We use it in all 3 vessels. I've even expanded it for use in vein grafts.
Unfortunately, you guys don't have the DABE. DABE also supposed to give very good result. There is a study done, comparative study done, DES versus DABE in ostial LCX particularly.
Vijay, you know, United States is so far behind the rest of the world.
DABE results were better than the stent. Yeah. And very, very good study and done very meticulously, and proper RCT comparing the two. And this study is from Italy, and very important study. I thought I must quote it.
Yeah, Vijay, the United States is far behind in a lot of ways. You know, we just got lithotripsy IVL just about 4 weeks ago.
Right.
And we were the first site to do it in New York.
Correct. And
I can tell you, you know, it caused a huge uproar. And you guys have had it now for, I think, 4 or 5 years, right, Dr. Chowdhury?
Yeah, we have almost 3 years now.
3 years.
3S. And Dr. Anirban Chaudhary, you showed so beautiful cases. All your cases, examples, it's wonderful. I mean, I
Thank
was
you.
thoroughly impressed by the way you have presented your 5 cases. And a particular area where laser you think will be a more valuable than the other adjunctive devices.
Yes, I mean, I have moved from a center where I use a lot of laser to a center where I don't have laser, and I'm still struggling to get the machine. I think what the big advantage of laser compared to your lithotripsy balloon, which is a very easy piece of kit to use, is a lithotripsy balloon comes with a certain number of shocks, and after that you have to use another balloon. Correct. And it increases your cost. So what I see colleagues doing, and I'll end up doing it psychologically at times, is if you have long lesions, which are fibrocalcific, you think I have to use this balloon for this whole length of the disease. And and you might land up not optimizing maybe the whole of the vessel. You have partially done for parts of the vessel. So I think lithotripsy is very handy if it's focal, but if you have a long lens to modify, I didn't show another laser case, which is very, very diffuse. The advantage of laser is you can keep going back as many times you wish. You use it, you go back with the balloon, you're not happy, you go back with the laser. The big advantage of laser is it debulks, while lithotripsy will sort out your underexpanded stent, but will not do much to the tissue, while laser does both. So for occlusive ISRs, I think it's a very nice piece of kit to have. And on top, if you had a degree of underexpansion, because it does both, it will debulk and it will help you to optimize. So I think it's a very handy piece of kit to have. And if you do have, just point blank.
Are you using laser in large thrombus burden cases too?
You can use that in STEMI cases. I used it. I used it at times, but you need to have flow.
Correct.
If you don't have flow, it doesn't really work. So if you have flow and a bulk of thrombus, a block of thrombus sitting, you can leave it for pharmacotherapy for 48 hours and bring the patient back. At times, if it's really a big blob of thrombus, it doesn't go away, and you can laser it. It works very well. It works in degenerative veins for the same reason. Yeah, but I think for ISR, laser, I think is occlusive ISRs, long lens,
correct.
can be very handy.
I was going through the distribution of use of laser in coronary. Almost 50% is large thrombus burden, STEMI. And almost 34-35% cases ISR, laser use. And as you said, it's for the diffuse disease, which I understood from you very clearly. Earlier, I didn't have this clear idea where to use laser. That's why I asked you this question. And you said that the IVL for a focal underexpanded stent, and for the diffuse, maybe the best is the laser, because it does both. It can be used for underexpanded stent plus a diffuse neoatherosclerosis.
Anirban, how do you get this OPN balloon in underexpanded stent? Because we have been getting in our lab very good result with OPN balloon. We can go to very high pressure, and the results are whether under expansion is the under expansion or the under deployment.
OPN balloon, let me explain, because Rajiv in America, OPN balloon is not available.
No, Rajiv cannot use it. Therefore, I asked it to Anirban Vijay.
That's right. Natural. You are asking Anirban, but I'm just enlightening Rajiv Jor about the OPN, because he may not be aware what is OPN balloon.
No, I have therefore
I'm naive to it, sir.
Yeah, I have asked Anirban Vijay. You are doing a mistake.
I know. Yes, you are asking Anirban.
Yeah, I guess it is. The main thing is recognizing where the problem is. My experience of the open balloons are, you deal with when you are doing the procedure and you realized the stent is not fully expanded. That's where I think open balloon works really well. So for and it usually works where it's fibrous. There's some calcification, but it's essentially fibrous. And you're expanding it and it's recoiling back. That's where it really works really well. And so what we try to do is, if that's the case, we take a 1-to-1 non-compliant balloon at a high pressure and I just leave it up for a minute till their BCG changes. Then I deflate it let the patient settle, and I do it 3 or 4 times. So trying to have tertiary creeps. If that does not work, then we try the OPN balloon. And it works. If you have had a recurrence and they've come back with a focal underexpanded segment, again, if it's largely fibrous, OPN will work really well. But if it's more towards calcific, I'm not sure it's always worth trying. I don't know the cost difference on top of my head. It's worth trying. That's where you probably need something which is going to affect the calcium itself or the very rigid fibrocalcific bonds.
And
It's
if there
definitely
is a
cheaper and it's
100%
definitely easier to
lesion,
use.
yeah, and Anirban and Rajiv, to both of you, if there is a 100% instant restenosis, how does it differ your maneuvering of the procedure? How do you plan the procedure? Sometimes nothing goes, it's like rock solid. It's like a CTO instant restenosis. How do you proceed in such cases?
So, well, first and foremost, obviously you have to cross that lesion with a wire. Once you've crossed it, I mean, I will, I did one on Friday actually, and honestly, a 100% restenosis are one of the easier CTOs to cross, because you have now you have essentially a path to follow. So I had a case of about 90 millimeters of occlusion in a gentleman who was symptomatic. That was clearly instant restenosis. And actually my fellow who was in the case with me is online here too. And we once we wired it, then we did, started actually with a 1015 balloon. And we slowly escalated our balloons until we got to the right level where we could do imaging. And when we imaged it, it was clearly an underexpanded stent that caused this dramatic neointimal growth. And then once we expanded it, it was really a 4-5 vessel that they put a 2.5 or 2.75 stent in. But again, the first and foremost, you have to just cross that lesion. And laser is a great technology here too.
Yeah.
Are you using laser,
agree with
Rajiv?
exactly what you said.
Yes,
If you do have laser, it's fantastic. But then going back to why it failed, and if you can correct it, that's the main thing.
Correct. And when it comes to, say, suppose a patient presenting with recurrent ISR, right? Raju said he considers brachytherapy as most important. Suppose you don't have a brachytherapy available. Like in India, we don't have a brachytherapy available. How do we treat this patient who comes back repeatedly? I don't like more than 2 layers of stent anywhere. So third layer, I absolutely, in my practice, I don't put third layer of stent, never.
Sir, the cabbage is not a bad thing.
Yeah.
But say suppose it's RCA, nobody agrees for cabbage.
No, but Vijay, nowadays MICS is there. You can go for MICS. Make a small incision, it's a focal, grafting. So surgeon can do it in a very short time.
Yeah, of course. But somehow the other, once you say CABG, maybe, by mid-cap, but patients don't agree with surgeon.
Vijay, what I tell my fellows, I said the difference between a good interventionalist and a great interventionalist is knowing when not to do something. And honestly,
well said.
after 2 or 3 instant restenoses, I have sent a patient for a right coronary bypass because this person kept coming back, and she was so upset with me, but she trusted me, and now it's been several years and she's never come back. So single vessel bypass is not the standard of care, obviously, and I agree with you. But in a recalcitrant patient that is not able to close that damn vessel off, I mean, either just close the vessel off, have an MI controlled and be done, which obviously is not ethical. I think a bypass is really the right choice.
But those are all very super dominant RCAs. They supply a large area of the myocardium.
It was a dominant RCA, I agree with you. But again, we just have to sort of treat the patient, and that's it. I know, Dr. Chowdhury, what do you do in that situation?
I would send the patient I absolutely support you, and I would send the patient for cabbage, If a patient has
I-
dominant RCA which is supplying a lot of muscle and the patient is severely symptomatic, we have done 3 attempts and the patient has come with 4th time with an ISR, we should refer the patient to for CABG. I
Correct.
think Vijay will
I
also
agree.
agree to it. Yeah.
Yeah,
Oh,
yeah, of course.
100%.
LED,
Yeah.
I don't have hesitation. LED, I
Yeah.
always propose. But RCA and CIRC, there is a problem. It's not easy to, propose surgery to those patients. So that's where I'm considering, what options do we have?
So Dr. Chowdhury, with the NHS in England, how would you handle that situation?
Yes.
Well, I mean, in fact, the laser case which I showed, I had to unfortunately put in a 3rd layer of metal. What I didn't show is that he had stable ISR, moderate ISR in the LED, which hadn't progressed, and he had a stent to the circ, which also had moderate ISR. I had suggested surgery to him, and his wife was quite with it, and he just wouldn't have it. But if you have a single vessel which is non-LED, you either have the patient, if it's blocked, I think it sorts your problem out. If it's an occluded ISR CTO, and it's a stable situation, the problem becomes till it becomes a CTO, and is a degree of instability. You give the patient the option of essentially you live with the symptoms, which potentially is non-prognostic, as it's in a non-prognostic artery, or you accept the option of a majorly invasive procedure, which we don't send, but that gives you the symptom relief. And you sort of leave it to the patient. I think that's what you do.
Correct.
I had a situation where, and I showed this in Vijay's course in Mumbai about 2 years ago, where a patient had in-stent right coronary restenosis, and despite using the highest pressures, I mean, I went to 30, 40 atmospheres, closed my eyes and kept turning, and I was convinced that it was going to perforate the vessel, could not open up that vessel. I use laser, tried laser bomb, which I know that we haven't talked about this morning, but I know that there's one of the questions on the chat about laser bombing. Use laser bomb, and it worked in one scenario. In another patient, it didn't work. And what I did use, which is very interesting, when laser bomb didn't work in the second patient, I used rotational atherectomy within a stent, and that vibration. And I used a 225 rotational atherectomy. The stent would not expand, and that worked. I blew the hell out of the stent, put another stent in, expanded it, and it worked beautifully. So we have a lot of options in our armamentarium.
Correct. Correct. So there is a question for Anirban. How there is any technique in using DAVE while you do the DAVE? Is there any technique that you require? How long to do it? How to deliver a drug fully?
I was just seeing the question, in fact. Yeah, I was just seeing the question. So, I mean, in general, the rules that I follow when you use a drug-eluting balloon is you prepare the vessel aggressively, preferably with some sort of scoring or cutting balloon, so you can make the cuts. Often use a non-compliant balloon. And if you're happy with the result of that vessel preparation, which is you have TIMI3 flow, your luminal loss visibly is less than 30%, you go with the 1-to-1 balloon sizing. I guess what this has been asked for. You go with the 1-to-1 balloon sizing, and most balloons it's a minute. Some of the newer balloons they say 50 seconds. I do not prepare the balloon outside the body, so I would not aspirate. Obviously, do not touch the balloon. Take the balloon to the lesion as quickly as possible, and essentially connect, neg, and go up. So I don't aspirate the balloon outside the body that we do, and stay for a minute. If it's within a stent, you can go to higher pressure. It's a compliant balloon essentially, but you can go to slightly higher pressure, and you take it out after a minute.
Okay. Do you use the Magic Touch, that Indian balloon?
Yeah, Magic Touch is available. You'll be surprised. I didn't realize it was an Indian company till pretty recently. In fact, the case I showed of the left main, it was treated with Magic Touch in London.
Okay.
So yeah, but it is available. It is more deliverable.
Okay.
you know, this
Any
is
other
sirolimus, so I don't
DAB
know.
available? Any other DAB available?
Yes,
No,
agent is tacrolimus. You know, majority of the DEBs is tacrolimus. So Magic Touch is the first sirolimus balloon that we
Yes.
have had available at our disposal.
Correct. And now there's another question. What setting of fluence and frequency do you recommend laser? Do you use contrast during the laser runs?
Okay. So there are, this is off-level
For both of you,
questions.
both of you. This question is for both of you.
Yes, so ISR, if it's within a stent, you have much more safety. Okay, so so within a stent, I would start off as 40-40. I don't go to the lower settings at all.
Okay.
Okay, and in general, I would probably go with anything between 3,000 to 4,000 runs, take it out, go back with the balloon, 1-to-1 non-compliant balloon, and see whether I'm happy whether it's given or not. If it's not, I go up again, give another 3,000 pulses, go back with the non-compliant balloon, and I still haven't given. Then the last 3,000 pulses, I go to 80-80.
Okay.
If it's within a stent, so in general, advice is you use saline because you're dissipating the heat. Within a stent, again, you have a degree of safety. So in general, it is suggested the next line is you do it without flushing. And if you have done a fair amount and you're a pretty skilled operator with complications, you can try the last bit with contrast or half contrast.
Okay.
Which I guess what you mean by laser bomb, I guess.
I agree, Vijay. You know, I think for instant restenosis, when I use laser, I go to the highest settings. I don't mess around with it. I just go to the highest settings. I feel very comfortable using it. For de novo lesions, I agree. Depending on whether you're using the 0.9 or the 1.4, with the 0.9, I go 40-40. I think it's a very reasonable start point. I don't go lower than that.
Correct. This question was from University of Maryland, who is a fellow in interventional cardiology, and he happens to be my son also. So
Yes, I know your son.
he knows, of course. Does any role of oral sirolimus in DES restenosis?
There's no data to support oral sirolimus.
This question is asked by a very large volume operator, Dr. Ramdev Yadave from Delhi, and very innovative one. He's a very innovative one, mine, and a good friend of mine. So good question. I like this question in case it is possible to treat by oral medication, nothing like it.
I don't think there's any data. It's like Trump saying, "Give me bleach to treat COVID." It doesn't work.
Trump is your greatest friend, I know.
Not.
So I think we have a very good session. And any more point, Dhiman? Any point?
Yeah, I was just asking one question to both Rajiv and Anirban, because we belong to different countries and we are really proud of you. Both of you have given so eloquent lectures, and with so, Anirban also, I have heard you previously, you too, Rajiv, brilliant lectures. So I congratulate both of you, and we'll be hoping that we'll meet soon with further elucidation on other subjects as well. Just I was going to ask one question, that how frequently now in the era of laser and brachy in your place, New York, how frequently do you use cutting balloon nowadays with Wolverine coming from Boston? And do you find any difference, or what is the status of cutting balloon?
I can tell you that when the original cutting balloon came out, it was, for those of us who are a little older, it was like a Palmar shot stent. It was a great technology. You just could not get the balloon beyond the proximal lesion. It was very cumbersome. It was very bulky. It was not possible. The latest iteration with the Wolverine balloon has given us more scoring options in these patients and be able to transmit that balloon distally. So I use it a lot more now with the latest iteration. But before, I used to have a bet with our rep, and I used to tell him, he used to ask me to use the cutting balloon, and I used to tell him, okay, I will use a cutting balloon, but if I can't get it down to the lesion, you have to get me a free one. And so he quickly stopped that because it was clearly not the best technology.
And his question, Ramdev Yadav's question was oral sirolimus. He's asking after opening the artery with the balloon, regular balloon, if there is a instant restenosis, first open it completely, 1:1, and then try oral sirolimus. That's a
Yeah, I
good
mean,
idea,
it's
but
a great,
there
it's
are
interesting.
no study to back it.
There's honestly, you really need local therapies. And I think systemic therapies here would not work. There's no data to support it right now.
Okay.
And you can use that, you can extrapolate this from the kidney transplant data, right?
Yeah,
Where
correct.
they used to use sirolimus and other immunosuppressives, and
Correct.
patients
It
still
didn't
came
work.
back with stenosis.
No, it didn't work. It didn't work. I remember, this is a good point that you raised, that sirolimus was used in kidney patients, oral sirolimus, and I remember this in detail. And I remember short study was done even for some cases where oral sirolimus was used in that time Ravel study. After the Ravel study, first time sirolimus was used in the Ravel study.
Right.
So sirolimus stent was used. Sirolimus coated stent was used in Ravel study. So sirolimus oral use was also attempted that time, but there was no clear-cut guideline how to use it, or no further studies done.
And if you remember, Vijay, the whole genesis of drug-eluting stents really evolved from the transplant data. The fact that the intimal hyperplasia and smooth muscle cell proliferation, and we extrapolated data from renal and put it on, and we said, oh, you know what? Let's get local delivery of this drug on a drug-eluting stent that will elute over 4 weeks and see if patients do better. And that's where Ravel came in. And clearly it worked, right? If you remember, the original sirolimus data, sirolimus was found on Easter Island originally. So, there's a lot of history behind this drug, but I think oral does not work.
Okay.
Can I just make a little comment?
Yeah, please. I was about to come to you if you want to add something.
No, yeah, I mean, this is slightly different. This is going back to the cutting balloon. I mean, I think, as Dr. Johar was mentioning, is in the ES era, one of the biggest reasons for stent failure is under expansion or undersized. So what has happened, I would probably say, especially in my practice and some of the others' practices, the last 2 to 3 years, is we have been using scoring and cutting balloons more in the index procedure, realizing that you have to get that right in the first place. This year in CSI, in last August, we had 2 great talks from Shamin Mehta and Antonio Colombo on calcification, and so the uses of Wolverine, which is way more deliverable than the angiosculpt. The way you take it, undersize it by 0.5, go to high pressures, you modify your lesion to get your first PCI correct. So what has happened is probably the usage of that piece of kit in the index PCI has made a comeback to compare to what it was a decade back.
Correct, especially if the lesion is fibrocalcific.
Yeah.
I mean, de novo lesion. You are talking of de novo lesion in index.
Yes.
Correct. So I think I think I fully agree with you. And do you think there is a role for the cutting balloon, scoring balloon in ISR also?
Yes, I mean, before you use your DEB,
you need to do cutting balloon,
especially if it's not very focal. If it's a bit more diffuse, you have to find a way how you can debulk it. And I'm not sure non-compliance do it enough for you to have a lasting effect. And obviously there were the old studies comparing cutting balloons with normal balloons, very likely from the bare metal stent era, suggesting cutting balloons are better than drug-eluting. So you cut it first and then you use a drug-eluting balloon. That's what we normally do.
Correct. And the size of the day is 1:1, or you use a little more?
1:1, yes. Because inside the stent you have the degree of protection. Yeah. So 1:1, slightly high pressures.
And inflation for a longer time, 50 seconds.
Yeah, 50 seconds to a minute. Yes.
50 seconds to 1 minute. Correct. So these 2 things. And do you rotate and again? No.
No, I don't know. I have a colleague who said there must be some drug left. If the lesion is 40, you've got a 30 balloon, pull it back and try it again. But I'm not sure if you're delivering something which is sticking, you would rather not mess with it a second time round,
So,
where you
but-
might have, even if you have a little bit of drug left behind, you might, in fact, pull it back into the lumen and throw it downstream. So I usually don't, do that technique. No.
I have one question that I always, think of it, that after you do a day for 50 seconds and you come out and then you do an angio to see whether you're, naturally you will do the angio after the day. So does the drug wash away with the pressure, force?
Well, I guess that will happen even with, with your normal blood flow. But I guess that's the reason you need to have, clefts or cuts, so that some of the drug is, is absorbed already into the tissues, rather than just being on the surface. And that's where I am a bit circumspect with sirolimus, because sirolimus is the least lipophilic of all the limuses. And whether, even if, forget the washing out, even if it's absorbed, how long it stays in the tissues and whether it has a long enough effect. If it's a biolimus, I can see potentially how, it probably has a slightly better effect than sirolimus, but, you use whatever is at your hand.
Correct. Dr. Ramdeo, as you said, he brought up a question in the chat about oral sirolimus and the Osiris study. And it's a very interesting point. The Osiris study came out in 2004, which looked, so it was really essentially pre-DES, because DES came out in 2003. And they showed that placebo versus low versus high oral sirolimus, whether you use a low dose or a high dose, the restenosis rate dropped from, I think, 40-some% down to 38, down to 22. But that was, if I recall, pre-DES. So it's one of the questions in the chat. It has never caught favor. I think the side effects of the drug, coupled with other issues, it never caught on. But it is an interesting point. He did bring it up in the chat room, so I just wanted to make sure I didn't blow it off.
There is one question by Dr. Keshav Ramaya. He's asking 2.5 millimeter stent DAB is better, or more than 3 millimeter DAB is better. Any comments?
Sorry, I didn't understand. So 2.5
asking 2.5 millimeter or 3 millimeters DAB is better. But we discussed this 1:1 size. No? The DAB has to be 1:1 size.
Yeah.
Correct?
Some people tell Vijay it should be 1.1:1. There is some recommendation like that also regarding this.
Okay.
But what do you guys do when you have very long restenoses? Do you use two balloons? Or do you overlap a little bit? Do you not overlap? That's
No, two balloons I have used. Two balloons I have
I guess
used
you have to overlap
for
a
a
bit.
longer lesion.
Yeah.
Distal first and then proximal.
So then you have a certain, again, I've never used DEB, so I'm a little naive in this.
Correct.
So how much can you overlap? I mean, do you release more drug in that local area?
If the lesion is longer, you have no other option but to use two balloons. A diffuse lesion, this happens in RCA particularly.
Right. Is it a cumbersome balloon? Is it a very difficult balloon?
No, it's not cumbersome. It's like any other balloon. It's a compliant balloon.
Okay.
It is a compliant balloon, but I would say it is not as easy to deliver as your normal workhorse balloon.
Yeah.
Okay.
You might even take some of the nice, like now in India you have your Supraflex screws. I mean, a 44 millimeter Supraflex screws will go easier than a 20 millimeter, 30 millimeter DEB. To put it into perspective, it is not as good as your normal balloon, but it is not like a Wolverine, or it's not like a angiosculpt. It's much easier than that.
Interesting.
Absolutely.
The Wolverine, which is a better version of the cutting balloon, the Wolverine still has bulkiness. It doesn't go easily into the lesion. You have to literally undersize the stent. Recently I had a patient with 2.5 millimeter circumflex proximal very tightly, 99%. Very difficult to pass the balloon. Somehow the other, I could pass 1.5 millimeter balloon, dilated the lesion, and then I tried 2.5 millimeter cutting balloon, that is Wolverine. It didn't go through. Then 2 millimeter Wolverine went in and post dilated with that after 1.5 millimeter dilated with the cutting balloon of 2 millimeter at a higher pressure. But undersizing, do you undersize your cutting balloon always with the vessel or 1:1?
No, this I changed my practice. In fact, after the CSI talk from Antonio Colombo, so I undersize it by 0.5.
Correct.
But I go
That
to
is what
16
the
to 20
Antonio Colombo
atmospheres.
says that.
Yeah.
Correct.
So previously I used to probably make it 3/4 and go to nominal. But now I undersize by 0.5 and I go to very high pressures. And I can see the logic of why he said that. And so at times it nominally doesn't give, and you tend to go to higher pressure. And if you have done a 1-to-1 balloon sizing, then you'll end up in problems at times.
Correct.
Can I ask Dr. Johar a question? Because I've never used brachytherapy. How difficult is it to set up the service?
You need a radiation physicist.
Yeah, which we will always have in the
You always
university.
have.
That's no
And
problem.
honestly, it's very easy. It was the Novost would love to, I mean, I think they would love to bring it into the UK and into India. You should reach out to them. I'm happy to help you with the process and have you meet some of the people. I have no affiliation with any of the companies, but I think again, like I said earlier, it's a great technology in the right situation. And I don't think England or India has it right now. And I think
India
No.
doesn't have it. England, I don't know.
Yeah.
No, I have not seen it, but I have grown up in the DES era, so I don't know whether they had it before or not. I have no idea.
Yeah, so I mean, it's clearly a good tech tool and good technology. It requires the Novost beta radiation system. It's strontium 90, and it requires a radiation physicist. And other than that, really nothing else. Correct.
So, any other point anyone wants to make, or any one of you? Dhiman, Anirban, Rajiv? That's it. I think we have answered all the questions practically.
Yeah.
And I think, let me see if there are any questions.
Just a last question to both of you, Rajiv and Anirban, that of course Rajiv doesn't use it, Anirban especially, that have you got any difference in the outcome while treating this ISR? Because as Bijay rightly mentioned, there is one study from Milan with 201 patients. Similarly, there are some data from Spain and other European countries. But a final meta-analysis has been done, but it has not been shown that one is superior to the other. And second question is that while choosing the DES, have you got any, more efficiency with the drug-eluting stent or hetero-drug-eluting stent? These are the two questions.
Yes, I mean,
short answers, yeah.
Short answers would be, if you can get away with a DEB, that is logically preferable because you are avoiding an extra layer of metal, number one. Number two, there is a concept that by having the drug through all the steno segment, you might have some advantage over a stent, which is a mesh. So the drug is not eluted in the entire ISR segment. It's still 20% metal to artery ratio, whatever. That's point number one. This is, if it's a focal lesion, I think DEB should be a preferred start-off point unless you cannot use it because of dissections or a lot of haziness, etc., etc. If it's a diffuse proliferative, where you're talking about long DEBs, I'll be amazed if that long DEB, overlapping DEBs, will come close to DES. So the more difficult the lesion, the more the long the lesion, I think you'll require a stent. And I missed the last part of your question.
I think in case selecting the DES,
yes,
would you select the homo DES, homo drug-eluting DES, or the hetero drug-eluting DES?
So there, if top of my head, I'm not very good with names, but there have been two studies. One has showed there's no difference, and one has shown having a hetero is preferable. The eye thinks slightly differently. And this, is if I think it's a difficult lesion, which are like long lesions, fibrocalcific lesions, CTOs, bifurcations, I think you need to have a stent technology which covers your entire healing period. There's no data for it, but that's how I think. So I will not use a product which has a drug elution of a month in any of those complex lesions. I would use a stent which has a drug elution of at least 3 months. Similarly, if I'm using DES in a longish stent failure, if I have an ultra thin strut stent with a longer drug elution of at least 3 months or longer, that would probably be my preferred choice, and a hetero rather than a homo. But the data is mixed on that.
And finally, imaging in 100% of ISR patients or not? Is it mandatory?
Well, I mean,
Good.
look, unless you can clearly see a mechanism, which is a stent fracture with a stent boost, or a stent enhancement, unless you identify the mechanism, I think that's what we should aim for.
Correct. So if there is a stent fracture, then you have no option but to deploy another stent.
Yes.
Yeah.
Correct.
Exactly.
So it's nice discussion and nice presentation. Both of you shown excellent cases. We learned a lot.
Yeah.
And I'm sure audience must have learned a lot too. And thank you very much for your kind support.
Thanks for having us, and it's great to meet Dr. Chauhan.
Yeah, and
we'd
love to have you.
I've never seen
We'd
one in my
love to
life.
have you again. And let me introduce Rajiv Dhiman. Is our NIC chairman, National International Council chairman in India. So I will share your number with him, and he will invite you to certain.
We'll be interacting frequently.
Yeah.
I have met Anirban also. He has come to Kolkata and he's from this part only.
Anirban, you're great. Anirban, your case is superb case.
Perfect. So
thanks for having us.
Anirban, if you reach out to me by email, we'll just sort of we'll chit chat.
I will share both of you.
I'll get it from Vijay. He's a good friend of mine, so I'll get it from him. Yeah.
Okay. Thank you, guys.
And very nice talks, both of you. Excellent talks. Super.
Thank you so much. Appreciate the time.
And Vijay, also you moderated the session so well. Thank you.
Thank you for your support, Dhiman. It was very good having you.
Thank you, gentlemen.
Good evening. Good evening. Good evening.
Thank you.
Thank you. Chalo.